members to this evening's Health and Adult Social Care and Overview Scrutiny Committee. First of all, thank you so much for agreeing the new time and us starting earlier. There is a quite heavy agenda. Can I have apologies for absence, please? Councillor Goldwyn.
Councillor Anang, Chair, who I'm subbing for.
Thank you very much. Councillor Williams. Just your microphone, Councillor. Do you want to say?
I'm subbing for Councillor Crozier.
Thank you. Just wanted to make sure you get a bit of exercise, come forward and backwards. Councillor Brown.
I'm subbing for Councillor Brenter.
Thank you very much, Councillor Brown. Can I sign the record? Oh, Councillor Brake.
Yeah, sorry, Chairman. I'm substituting for Councillor Barrett.
Okay, thank you very much. Yep. Thank you, Councillor Brake. Members, can I sign the record of the meeting held on the 16th of June as correct, please? 2026. Agreed. I have no urgent business to announce. Are there any disclosable pecuniary interests or other significant interests or any declarations of whipping this evening, members? None at all. And before I move on, I just want to say we're delighted to have the Chair and Vice Chair here from Children's Overview and Scrutiny. You're more than welcome here, Councillor Scott and Councillor Mandarakis as well. I just wanted to say that we were at that meeting too. I was subbing, but it was really good to be able to observe the ADHD item we've got coming up shortly. So if members are in agreement, when we go to the ADHD item and we have the introduction, I'm just going to ask Councillor Scott and Councillor Mandarakis just anything they want to add from. We are talking about adults here tonight, members, not children. But I know there is transition and everything else through the service as well. Just to remind everyone, I also want to say, can we please welcome Councillor Verville to the committee at your first HASC. Welcome to your first HASC meeting tonight. And I want to also take this opportunity to thank Ed Waller, who leaves the ICB at the start of September. And thank you for your time you have given. We're going to thank you now, Ed, because it may not be many thanks coming when you come and sit up here. I know sometimes our challenge can be a little bit difficult at times, but we remain appreciative of the time and input you have given to us over the many months and you've been here, Ed. So thank you very much for that. Members, just to remind you again, we have a very heavy agenda. I'm going to be very tight on questions. I'm going to be very tight on interjections as well. But I thank you all for being flexible and for allowing us again to start, like I said at the very beginning, at this earlier time. And can I remind all presenters of reports to keep the introductions to a bare minimum and to remind you all that members have read the paper, take the papers have read, that they've read the papers. Okay, we're going to move to item 5, changes to ADHD and autism services. Ed and Kate coming up, I think. Welcome both. Ed, do you want to, and Kate, do you want to do any introduction to?
Yeah, good evening, thank you. The paper that you have in front of you is the same paper that went to the Children's Committee. I think you've got the summary of the conversation we had last Wednesday. The reason for the conversation is that we are currently experiencing a combination of factors which mean that we've had to take the commissioning action that you are scrutinising today, and those factors include a very significant rise in the demand for ADHD and autism assessment, and quite a significant change in the market of providers that are providing those assessment services. So the paper contains the numbers, financial numbers, showing the increase in expenditure which the ICB has made over the last few years on assessments. The financial numbers you've got are the assessments that are done outside of what we call the statutory sector, so our NHS providers, mostly by what we call right to choose providers, and adult assessments are almost entirely done in the right to choose sector. So a good proportion of the expenditure that you're seeing rise is adult assessment for both ADHD and autism. Now, as we discussed at the meeting last Wednesday in relation to children, where we actually have better data than we do for adults, one of the things the ICB is grappling with is the relatively poor data that we have in this area. And that results from a few things. It results from the fact that some of our right to choose providers are not obliged to give us the data in quite the way that our statutory and commission providers are, and because we think there are patients who are actually on multiple waiting lists because of the nature of the sector, and because there are people waiting for both autism and ADHD assessments. So at the moment, we're undergoing a data exercise to clean all that up and deconflict it, to work out precisely how many people we have waiting. In the short term, what we've done is the same as we do for all our commission services. We have described for each of the providers we buy services from how much service we want them to provide. We do that through a mechanism called indicative activity planning, IAPs. That's part of the standard NHS contract. Each provider has an IAP that says how much activity they can do. And the recent communication that started happening for patients is a communication from those providers to say what the likelihood is that that patient will get an assessment anytime soon. The reason they're communicating with patients is that we have described some clinically based criteria to prioritise people waiting for assessment, starting with high priority assessment individuals. And you can see in the paper the criteria we're using for children, which we're now shifting over into the adult sphere. We're still in the process of engaging and finalising those assessment criteria, but that's what is being used as a guide. And we are also prioritising those who are in treatment, i.e. they've had an assessment, they may be on medication, for example, they need a regular review by the provider. And after the providers have met the needs of those groups, then they will do a certain number of new assessments based on their indicative activity plan and how many assessments they can do within the amount of activity expressed by contract value that we've set them. So that's the explanation of what's in the paper in short. I don't know, Kate, if there's anything you want to add?
Yeah, I should just... I don't think that's working, is it? Yeah, is away. But he came to the Children's Board last week. But as Ed says, we have basically used the clinical prioritisation criteria that have previously been developed with everybody for the children's service to now apply the same principle to the adult service, because we really want to make sure that people get their assessments in their clinical priority order and not simply based on at what point they went on the waiting list.
Thank you so much, Kate. Thank you, Ed. Councillor Scott and Councillor Mandaracus, I'm going to go to you first. Obviously, I've said, members, I'm going to be very strict on this adult we're going to be talking about tonight. But again, it's really important for you just to hear that maybe a bit of an overview from Councillor Scott and Councillor Mandaracus on your thoughts of the children ADHD services and what you heard at the meeting too. Sorry, I threw that at you unprepared, but if you want to just feedback in any way you want to.
Obviously, we're troubled and concerned, and we continue to be troubled and concerned that the ND pathways rights to choose are proposedly being halted. We're worried that there's no commissioning at the moment, and there's also handovers because how can I say, our Parent and Carers Forum and my inbox, and I know yours as chair, parents and carers and the community were not aware of this, you know, so I wonder how they thought that the message would get out there, you know, and then people just panicked. And, you know, some of these people have had appointments cancelled, have been waiting, and you know, they just think it's not satisfactory. And obviously, I know I'm not here to talk about adults, but, you know, KCF-HF, you know, has done, is it fair to say, a very poor job with the adult services. You know, is that why it's all being streamlined? And, you know, we want the best for our residents. And, you know, if our children are waiting 60 months, that's a long time for a 5-year-old. That's a long time for a teenager. And, you know, I know some of the panel, Councillor Cook, they've got lived experience of what that's like and how detrimental it is to the future, to outcomes for children and their families, life chances. And actually, you know, you have to plan, do, check. I understand the Integrated Care Board are under a lot of financial pressures at the moment and they're having a massive restructuring. But it would seem to me there's a lot of chiefs that are unacceptable.
Thank you so much, Joe. Councillor Menderekers?
So I think Joe summed up a lot of how I felt about it from a children's perspective. I said last week, and it's not really changed, that I don't see it as anything more than a budget management. I don't think it's going to lead to any better outcomes, and I'm still unconvinced on that. But from an adult's perspective, and actually it would affect children as well, I've had people in my inbox who have they're already in receipt of, I spoke about medication and the reason that I think it's applicable to children, but they're already in receipt of medication for ADHD based off a private diagnosis that I'm not clear if it was through the Right to Choose, but it was through a provider who is on the Right to Choose list. So they were given a diagnosis through that. And now their doctors, their GP has been told to not prescribe. They've been told it by the ICB. I'm not really sure why, and I'm not really sure how, just because it was not an approved, it was just because it came through a Right to Choose provider. I'm not really sure why people are being denied access to medication that has been a part of their care plan, and how they're supposed to then cope and carry on through life when they've been in receipt of medication for years. Just wondered if you could answer that. If that makes sense.
Ed and Kate, would you like to answer? Or do you want to comment on anything that
yeah,
Councillor Scott said as well?
Just clarify that there is no pause to assessment. What we've done is ask every provider to live within an envelope. That might mean that some individuals don't get an assessment as quickly as they would want, and frankly that everybody would want if that was possible. But we've not asked anyone to pause entirely. During this financial year, the providers are given an envelope and asked to live within it, which means they have to work out how they're going to do that and communicate to patients accordingly. And we are still commissioning. We are still spending well above, well, you can see in previous years, well above what's been budgeted for the service. We expect this year that the budget we originally set will be breached. It is important as an ICB in financial deficit that we do control the budget. We do spend the budget we've been given responsibly. Anything we spend here is going to have to come from somewhere else. So there is a trade-off, and we are spending more here than we plan to. On the individual patient cases, I think I can't really get into that here. I don't really know enough. Kate might want to add. I don't think I can have enough from that description to know what might be going on. But obviously we're happy offline if anyone wants to approach the ICB.
I can probably add as a point of principle that the NHS does not pick up prescribing that started in the private sector. So if someone has had a private sector prescription, the NHS does not pick up the ongoing prescribing of that.
But if somebody has been being prescribed it, has there been a recent change that would have stopped that? Because as far as I'm aware, this person has been in receipt of it for years and has been told by their doctors in the last few weeks that the ICB have told them they're not allowed to prescribe it anymore because his diagnosis came through a particular route.
As Ed says, we're happy to look at individual cases, but as a general point of principle, no, that hasn't changed. The NHS does not, and that's a long-standing thing. It should not be picking up prescriptions started in the private sector. Happy to look at an individual case separately.
Okay, I'll apply.
Councillor Scott, just one more, and then I'll move on to the others, and I'll come back to you guys anyway. You can
As
join in.
much as
You can
it
join
is-
in today. So.
As much as it is a pleasure to be at your committee, Dan, the last time we were invited, you made it crystal clear as Chair of Scrutiny for Health that you wanted us to be engaged and consulted as part of the decision-making process. And in fact, we were, Councillor Manderakis and myself were only here also with Councillor Joy, who's our opposition spokes for children, because we'd been, you know, how can we say, worked around and stuff was coming here rather than to children's. And we need to get this message loud and clear to the Integrated Care Board. We're here you know, not for our own health and well-being, but for the nearly 290,000 residents, of which 65,000 of them are children and young people. And you need to communicate and you need to get it right. I'm not even sure if it's illegal to put a full stop on the right to choose.
Thank you, Councillor Scott. Ed, before you answer, I was just going to say, making it very, two things I need to make clear. Obviously, Councillor Joy was invited, opposition spokes were invited. We'll share it, but Councillor Joy is away. So I just want to make sure we were going to have a full set, everyone was invited. The thing I will just make a point of is what we said. I think our closer working is critical, especially on transition from young people right up to our older residents. And I know Ed and we have spoken, haven't we, Kate, as well, but we have spoken offline from here about how you're going to integrate that more. And it was at our agenda planning, Councillor Scott, you know, that I said to the ADHD, would they go to you first, then come to us, even though it sits under us. It's key when there's children involved. It's key to hear what your parent forums and what your members around your table are thinking. I think it's key. That will continue. As far as we're both concerned, that's going to continue. And I'm sure that same sentiment is held by the ICB, hopefully. Ed, did you want to come back on what's been said?
Yes, that sentiment is held by the ICB. Just on clarification on 2 points, there is no restriction of the right to choose going on. The referrals that are being made to whichever provider the person having the referral wants it to be made. And so there's no restriction of choice of provider. The thing we have done is being clear what the number of assessments and affordability within the year looks like in the context of a very significant increase in demand. And the other point I would say is on the communications. It was unfortunate. I think we accept that as much as anyone else, that some of this became, some of the IAP-related communications became public when one of the providers started talking to patients ahead of the ICB's communication. So there was a plan to communicate in a coordinated way. It didn't go quite as was planned. I can only apologise for that. I can't rewind history, but that was the intention all along.
Thank you very much. Councillor Scott and Councillor Manning, obviously, please join in the conversation. If you have any other questions, bring them in as well during this process. I was going to go straight to Councillor Cook, and I'm going to bring in Councillor Galvin because it's a looked after children bit, because then we're going to move on for the rest for the debate and questions, which is important. Councillor Galvin, you've got a slight comment to make about looked after children. Is that right from the last meeting?
Yes, that's right. Thank you very much, Chair, and certainly to follow on from the Chair and Vice Chair of Children's. I was very disappointed last week that you did not seem to be prepared to move the categorisation of our looked after children from 2A into 1. And that was really brought home to me this morning, because I sat on a fostering panel this morning, and 2 out of the 3 cases we dealt with this morning, the carers have been waited for some considerable time for an assessment to be done. Our carers are looking after some of the most challenged children we've got in Medway. They do a brilliant job, but I think it's incumbent upon us to, to ease where we can again. And if the Vice Chair could take that on as a recommendation, please, I'd be very, very grateful, because I think it is important that our looked after children are in the same category as service children, because I think whilst the Armed Forces Covenant is brilliant, I wouldn't take that away from anybody, but I think our looked after children are just as much, or if not far more, under stress than service children are. And also we did have another discussion on this at Friday on the health subgroup of the Corporate Parenting Board. So it is across not just members, but also the professional people involved are concerned about this. So I would ask you please to look at that again. Thank you.
Just for members, just for members to know, the Vice Chair will say that when we finish debate. What we're suggesting is to move looked after children from category 2A to category 1. That's the recommendation. Yeah. yeah, so but we picked it up at the end. Ed, did you want to come back just quickly?
Just to say, I think George, our clinical lead, described how this worked at last week's meeting. I think what he was trying to describe is that it's not as simple as one factor determining the prioritisation or not of a child's assessment. There's no dispute that looked after children have lots of needs that need to be met, and he was very clear that if a looked after child warranted an assessment as a priority, then that would happen by reference to other factors. So there is no, I don't think there's any argument on our part that that's an important thing to get right. I would just say that this is a clinical prioritisation that's been developed collaboratively. I have no objection to asking people to look at it again, but if we could ask the clinicians to do that and to come up with the right answer, then that would be I think the appropriate way to take it forward.
So with our recommendations, we'll work out that route, won't we? We'll work out that route. I've got Councillor Cook now. Councillor Cook.
Thank you. I'll try and keep my questions brief and focused on adults. You've heard my story before. You know I've got lived experience of an older child, but I think I'm really conscious you've had the debate about young people. So firstly, I think I'd like to understand whether this is usual practice for a medical diagnosis. You know, has this happened before with any other kind of medical conditions? Because I was sitting there thinking I couldn't imagine if we said, okay, we can only diagnose X number of cancer patients, or X number of patients with broken arms. And then I looked, you know, further through the report that suicide is the main cause of death in ages 10 to 35 years. So it's not like this isn't having a significant impact. And I could quote many other statistics about the effect on mental health of somebody being autistic, particularly somebody not being diagnosed. And I'd be very curious, and I don't think it's something we can answer here, how many death certificates actually say undiagnosed autism and how many say depression, anxiety, somebody didn't know who they were. And so I'd like to know whether this is usual practice in terms of has this happened in any other type of medical care? Because I feel like these are people who are often perhaps not as able to advocate for themselves, and I want to be certain that we're not putting an unusual practice on this group. Secondly, I think that there is a fundamental human right to a diagnosis, not just about access to support, but about understanding who I am and why I feel the way I feel. And I've just used the suicide and self-harm example there. I can see in, you know, looking at the categorisation, the impact of self-harm. I don't know that when self-harm is looked at, the question of might there be the need for neurodiversity assessment is always asked. From the stories that I've come across, that isn't the case, and things are treated separately. Also, I don't know that
Sorry, Councillor Cook, do you want to come on them too, or are you okay taking on, because there's quite a few, there's some really good questions there and I don't want to lose them.
Shall I come back on the first one? Because I think I didn't know whether the second and third were about to be related. On the first one, it is common practice for NHS contracts to include an indicative activity plan. This is by no means the only contract that has one. In fact, it's a standard part of the NHS contractual framework. If you look at other clinical areas, you will see clinical thresholds for treatment. You will see clear requirements for prioritisation according to need in terms of the time patients are seen. And I don't, Kate, if you want to add on that front.
Yes, it is very common practice to have these plans in place, and we do link them to clinical prioritisation criteria so that we make sure that the people who need the most urgent treatment or assessment will get it first. So yes, is the short answer to your question. This is a common thing.
Thank you. I think it probably does come into the next question, because I think it's that question about masking. And if you are somebody who doesn't know you're autistic, but you have very different profile, and yes, between school and home, but we're not talking about children, but let's say between your outside face in the world, or the way you present, and what's happening behind closed doors, I'm really concerned about this categorisation. It isn't as simple as I've got these markers, I've got this, you know, I don't understand how we can be certain that somebody is only a category 3 when the whole process of autism is about masking. I think that's my question on that bit, Chair.
So I think what I'd say is these criteria to be applied to people who have come forward for an assessment. So it's a way of categorising the people who've already put themselves forward based on criteria that we think will help us identify those with the most urgent need. The adult criteria, I should just repeat what Ed said, they are currently being engaged upon because they were originally developed in the children's and young people's space. So these are already people who have come forward. And then this is about seeing which of those our providers should see first for their assessment.
Yeah. Thank you.
And just very quickly, this is not a uniquely Kent and Medway problem. This is a national issue where these issues are being debated in every ICB with every local government body around the country because of the connections between NHS and local authority pathways for different services. One of the big underlying factors is the extent to which the demand for assessment has risen.
I think it's just that just because there's high demand doesn't necessarily mean that we should reduce the access to that demand. I think that's probably what we're debating. I think that question then moving on to, well, we have support. And I think I remember we've had this conversation before, and I read the report very much as, even if we can't give someone a diagnosis as quickly as we'd like, we have a commitment to make sure they have support. I think very often my experience is the support is knowing who I am, not necessarily attending this, that, or the other. And actually, I know the barriers of my kind of loved ones and people I have also worked with is that they don't think the support's for them because they might not be autistic. Because it's such a binary diagnosis, the focus on being autistic, it's which category do I fall in? And what if I start the support and then I find out eventually that I'm not autistic and I've done the wrong thing and I've broken the rules? And I think there is that, there seems to be in my mind, a kind of link between the support being the kind of, you get the diagnosis to get the support. But I think very often in autism, actually, for some, yes, but for some, the support is knowing who I am and getting the diagnosis. And that in and of itself is the support which is required. I think secondly, then there is a conversation around what about these wider medical complexities? So I've mentioned before, people who are being treated for bladder issues. You've put eating disorders in there. I was pleased to see that was being taken seriously. Undiagnosed chronic pain syndrome, a massive factor in autism that, again, lived experience, physio, paediatric trauma consultants, MRIs, neurology, go through all of that before somebody says, oh, I wonder if it's related to an autism diagnosis. If we had the diagnosis, medical professionals would have to start with that rather than these individual elements of pain of these issues being taken. So I know I'm going fast here, just to keep going. As I say, I think there is a real concern here that those who aren't in crisis are those that are at the kind of bottom of the pile, but I'm really concerned that for this community, and that's why I feel so passionately about it, very often there is less of an ability to advocate for ourselves because the bit that is not seen by professionals is the bit of where the danger is. The self-harm, the potential suicide. And actually, you say, but people being on the pathway, but I think there is a real concern in this about kind of closing down and closing doors. I'm really concerned about how we've got to the point of not having the data. And again, I know that, you are picking up lots of information from previous, I've been in this committee for a little while now, but again, I just feel there are so many other communities that we just wouldn't sit and say, well, we just don't have the data. We just don't know how many people died in childbirth. We know, we've got the information. And it feels like this is a community that have been not advocated for, which is why I want to speak so strongly. And I think lastly, and I think this is perhaps, I'll sneakily get it in because it might be moving on to children, but the bit around school attendance, and I wonder, let's think about those with the HCPs up to 25, and then the chair might let me get it in. But, that if you've been homeschooled for 12 weeks, then you move up. and I run 2 attendance and behaviour hubs. What's to stop parents who are needing a diagnosis for their child keeping young people off, away, out of school or out of their provision for young adults in order to move them up the criteria? I think there's a real safeguarding risk there. So I know that's, you know, a lot of personal view there, but thanks, Chair, and thanks for the time.
Ed, okay, any response back on that?
I just addressed the last one, and then maybe Kay might pick up some of the wider clinical questions. On that last one, what you've got is a summary of the criteria. There is more detail behind it. I am reassured on that point that it's very clear that the danger you're describing isn't likely from the way that the assessment will be made.
I think it's that there are those who could pay for a diagnosis who will just pay. There are those who can't and will do anything. And if that means being at home with my child or my young person, that's what it takes. That's what I'll do. I think that's my concern.
I understand the concern, but what you see there is the summary of the way the assessment will be made, which I am told by those who make it takes account of the sort of risk that you're describing.
Kate, do you want to add on?
I just wondered if I should just touch on people getting support based on who they are. So absolutely understand that some people want a formal diagnosis, but some people want support for the way they are, which is why we're focusing on the "this is me" ethos of it. So getting access to support is based on your needs, not your diagnosis. So we would not shut someone out of getting support because they don't have a diagnosis yet. We are looking for needs-based support. So someone might realise they have a need, access the support. Some of those people will go on to wanting a formal diagnosis. Some of them will say, I have the support I need now, that's enough. I don't feel the need for a diagnosis. So it's very individualised, but we absolutely don't put a barrier to getting support from not having gone through an assessment yet.
Chair, sorry, thank you. My worry is that if the support I need is for anxiety, food, pain, and I don't know that in the middle of that is autism, or I haven't had a doctor tell me, which is actually what, you know, really matters for some autistic people, I am concerned, and actually lived experiences, that people will be treated for the eating disorder over here, the anxiety over here, the chronic pain over here, and the bit in the middle that says, actually, this is you. It's almost like we're sort of diagnosing by stealth, because somebody at some point is going to say, well, this person's on a pathway, so we're going to assume that they are autistic, or we're going to assume they are neurodiverse, and then we can then make the assumptions about how to treat those issues and provide that support. So we're sort of diagnosing by stealth anyway. We're just doing it without the formal different. It kind of feels the wrong way round. That's why I can't get my head around it.
Thank you. I think all I can say in response to add to what I've said is if at any point any of the clinicians that were interacting with a person felt that they might have an unrecognised diagnosis, they would discuss it with the person and ask whether they wanted to go ahead to be having a formal assessment. And that could come from any of those places of the support the person's getting. So there's no barrier to them then going forward for assessment. And then if they were put forward for assessment, they would be triaged through the clinical criteria that we've got here, and then they could get an assessment.
Thank you so much, Esther. Thank you. Councillor Jackson.
I echo everything that Councillor Cook says, and you know that I have 5 young people now that have a diagnosis of ADHD and autism, and I got contacted by members of vulnerable, and we are talking about young adults now, we are talking about over 18s, and when they heard this news, couldn't understand it, and we're all sitting around here as councillors asking you questions because we don't know how we got here. And it's it's, how can I put this? It's very okay for you to say, sorry, it got out in the press before we knew it, but you weren't honest about opening that line of conversation. You were already down the rabbit hole, if you like, for it to get out into the press. And lots of vulnerable young people, that was their first indication of this is what was going to happen. And as Councillor Cook said, as you know, in vulnerable young people, self-harm and suicide when they feel, and even just mental health. As you know, my daughter is having therapy every single week because of diagnosis being delayed and everything. We really need to look at these secondary conditions that are being caused by this and the ripple effect. Now, we sit on this committee all the time and say that communication, when we sit there and we look at complaints, and the top one is always upheld our communication. When are we going to realise that communicating not only to us but to the people of Medway, to the vulnerable young people, are we reaching out to support groups before you start making the decision to say, look, this is going to come out, whether it came out quicker than you thought it was going to come out? We need to be putting barriers and safety around these communities that are not advocating for themselves, but are actually very, very vulnerable. And we have to remember that not communicating properly sends ripples out into these communities that can be really, really harmful. And that's, you know, these are people, they're not a diagnosis. They're not even support, if you like. These are people that opened that paper, went online, saw this, and their whole world crumbled. We really need to be thinking about communication at every step of the way. So it is a plea rather than a question. Please, next time, I feel like I've been saying this all along, but please communicate to us, communicate to the people that it might have an impact on. So they're not going online and hearing about this from that, because that is where we need to start if we're looking at health and mental health.
Thank you, Councillor Jackson. I mean, Ed, do you want to, and Kate, I mean, it's a really well-made point about that. I know you mentioned about the communication going out, and it was unfortunate how it went out earlier and it was different. I mean, how did it happen?
Well, so if I start at the beginning of the story, we are spending tens of millions of pounds more in the last financial year. We spent tens of millions of pounds more than we did the year before. So I want to dispel any idea that we are somehow doing less assessment. We are doing more assessment than previous years. What is happening is that the demand for assessment is rising even faster. So that is a tricky thing to deal with. That is something that every ICB is seeing as a phenomenon. But it isn't that we're reducing spend. You can see it from the numbers in the paperwork. So what we're doing is trying to manage people's expectations about when they'll be seen, because that's the right thing to do, to help people understand where they are on the waiting list, when they might get their assessment. That has been part of the system as it's operated for some time. The primary route by which people should hear about the time of their assessment really has to be from their provider, the healthcare provider, about when they're going to be seen, because the ICB can't describe that in terms of clinical prioritisation, because that's not our role in the system. So the idea was that the communication would go to those who are on a list from the provider whose list they were on, explaining what they might expect, and that is a bit different depending on the individual, the provider, etc. So what has happened is one provider's communication went ahead of the plan, which was there for us to communicate to scrutiny committees and others in order to describe what was about to happen, and then for individuals to get communications from their provider about their place on the list. It is not something I would design. Frankly, you know, if I had my way, everyone could be seen more quickly. So there's, you know, we would love, I think, in the perfect world for the waiting times to be shorter. We're trying to manage the three factors here where people get the right to choose where they go. we try and meet as much need as we can for people to have their assessment as quickly as possible, and we balance the finances of the ICB, which are the things we've got to triangulate.
Thanks. Sharon, if you're coming back with a question, if it's got big
quick one.
questions, I need
I just wanted to
questions now.
say, the minute you came back, you started talking about money and reducing, and that is my point. Communication is not about, if you had communicated that in the public domain, that there was going to be a change to the service, it doesn't cost anything to do that. But so that, I mean, it is just, but you.
So there's not a change in the service.
No, this is what I'm saying.
What has happened is we have described to the providers of the service how much of the service we've bought from them. They then need to manage what that means for how many people they can see and when they're going to see those people using clinical prioritisation. The pathways are still the same. The referral mechanism is still the same. People are waiting longer than we would all like, but that isn't a new thing. That happened. That has also been true for a little while as well. I'm not saying that is acceptable or desirable, but that is what is happening at the moment in these pathways because of the demand we're seeing. So there is no change except that contract volume and prioritisation requirement.
Okay, I think we can come back to it. I'm going to go to Councillor White and Councillor Shocker. I think, please correct me if I'm wrong, Councillor Jackson. I think what Councillor Jackson is saying is the nub of the issue is residents at first, when they got that communication, it worried the hell out of them. And I think we can't, I know you don't forget that. I know you've mentioned it a few times. We can't forget the impact of that poor communication by your partners at the beginning that caused concern from many, many parents. And I think we mustn't, that doesn't cost anything, that communication, doing the communication the right way. I think that's what Councillor Jackson, tell me if I'm wrong on it. Councillor Wadey.
Thank you. I think Councillor Cook especially covered lots of my questions, but Councillor Cook and Jackson both spoke brilliantly, and the councillors from the children and young people, I think we as a committee support everything, yes, you're complaining about and doing. But to ask questions, people requiring assessment or treatment or however they're categorised, when or if do you think that will peak? And are many of these people being treated in other ways that may be the wrong way? If they've been misdiagnosed for another complaint, mental health issue, etc., because this report does seem to keep going back to money. So if you're treating them correctly first time, that would, benefit other budgets, which isn't the reason you treat people right the first time. But for all of that, you need diagnosis. So I'm a little bit concerned that you're treating people without diagnosis, then offering them the ability to go for a diagnosis. And as lay people, it seems back to front to all of us, I'm sure. And one other question, your providers, do you trust them? Because, do you trust them all equally? Because, again, from the report, I have some doubts about that.
Shall I start with the issue of treatment? So what we are offering is support to people for their needs. That's a different thing than treatment, because often there is no treatment. There's no treatment, for example, that can stop someone being autistic, but we can help, it may help people understand why their needs are as they are. Your worry about people being treated perhaps in other spheres, and you mentioned mental health. I would expect a mental health professional to recognise if a neurodiversity is part of the problem that the person they are treating for mental health issues is presenting with, in which case there's no barrier at all to that person then going ahead for an assessment. And indeed, depending on the criteria, they may be one of the more urgent people for assessment.
So can I just come back quickly? But all of these people, the numbers have been out there for many years, we assume. None of them, the adults I'm talking about now, none of them would have been diagnosed, because that is a relatively new thing, going by the numbers and the money put into it. So I'm assuming they had problems. And if all these professionals had said, oh, but your condition is ADHD or autism, then surely they would have been diagnosed or treated 10 years ago, 5 years ago.
So the number of people coming forward to say, I think I may have this, has gone up. There simply were not this number of people wondering if they had this diagnosis waiting for an assessment before. It's going up not just here, but across the whole country. I remember you questioned when might it peak, and we do not know. The demand for assessment is just going up and up at the moment. So I think what's happened is people are very much more aware now that some of how they are feeling or how they are presenting may be due to a neurodiversity, and that motivates people to come forward for an assessment. So I don't think it's that these people were sitting there unassessed. I think genuinely more people are coming forward and saying, this might be me.
Okay, thank you, Chair.
Shall I talk to the provider question?
Please.
And just to be clear, when I talk about the spending, the point I'm trying to illustrate is that there is an implication in some of the questions that we're cutting down the number of assessments we're doing. I'm simply making the point that the number of assessments we're doing based on the amount we're spending is rising. The provider sector in this area is complex. So we have more than 40 providers currently providing assessments for children and adults. 2 of those are statutory organisations in Kent and Medway, mostly children's assessments. Then we have our right to choose providers. Some of the providers are commissioned directly by the ICB, and some of them are not. And under the NHS framework, a provider of certain services that has a contract with another ICB can provide to us under the terms of that contract elsewhere, and we pay the bill. Now, that means that we have to manage quite a complex market. Other people have decided the terms on which some of those contracts exist and are managed. Like any growing market, there's a variety in the provider sector of business models and approaches. I think, we have to start from the basis that those who are doing the assessments are qualified to do them, and that means they're doing them in the right way. But obviously, the quality of the assessments that we're getting from our providers is something we're very keen to make sure we are clear about on an ongoing basis. We are thinking about how we might use clinical audits and other things to make sure we're getting the best possible outcomes, and we will manage the provider market accordingly.
Thank you very much. Just your microphones there, Councillor Wadley. Councillor Shock, if we have questions, please, that'd be great.
Yeah,
Thank you.
thank you, Chair. Chair, the first question might be towards you. Obviously, the report states there's no adult clinical categorisation framework. It's in its draft format at the moment. Should this have been going ahead without that, just out of curiosity? Oh, was that?
So the clinical prioritisation framework is in development to try and make sure that we echo what's done in the children's space. At the moment, it is for each provider to decide on the basis of their prioritisation. Okay. We want to make it more standard because we want to make sure that it's equitable. So
there's not like a statutory duty on that now then to provide that framework? No.
So they must operate in line with good clinical practice. So we would expect that they will have their own clinical prioritisation services. We're trying to make a standardised one so that we can confidently say that for everybody that we provide services for, they will have gone through a prioritisation framework that looks like this.
But in essence, then they could differ.
At the moment, it could differ, which is why we are very keen to make sure that we set some standardisation around it.
I think it's important it is unrealistic to think that everyone on a waiting list is going to be seen tomorrow. I think it is probably common sense that if you are prioritising, you have to do so on the basis of clinical factors. So we need the clinicians to make the decision about who is prioritised for assessment sooner rather than later. We are trying to bring some standardisation to that in the way Kate describes, but the principle of clinical prioritisation in the context we've got, I think, is an important one.
Okay, thank you. So my next questions are going to be on cost initially. Ed, obviously I appreciate the national situation we have here, which is getting quite a bit of media attention, and there's a lot of misinformation being thrown about by various political parties, particularly one at the moment, and they're kind of gaslighting millions of people with ADHD. But focusing on costs, has the ICB benchmarked Kent and Medway's cost within neighbouring ICBs or nationally? Have you benchmarked our costs versus other people's?
Well, it's slightly more complicated than that because we have commissioned providers, as I explained before, and we have providers commissioned by other ICBs who are providing services in our area. There is, under the terms of the variety of contracts, therefore, operating a variation in price. But because of the right to choose framework, the choice is with the patient as to which provider they go to, and the terms of the prevailing contract are what we pay. So we do have an idea about what on face value might look like the cheapest or the best value, and the variation, but not all of those things are within our gift to change.
So what I was trying to get at, so is it other ICBs or nationally who have like lower costs than us? Are they doing something different with these providers? Is there anything that we could do better locally?
Well, so we are in our commissioning, our direct commissioning, we are striving to get the best possible value. There is a national discussion going on about standardising tariff prices, and there is currently emerging voluntary tariffs in some of these assessment areas. And that's a mechanism where you can bring consistency, because in lots of procedures, particularly in the acute sector, there are standard national prices for particular services. We don't have that in this area yet in a compulsory way, but that is a live discussion nationally currently.
And is anything additional you could add to a strategy to improve financial efficiency with this in this sector, do you feel, coming from a commissioning background?
Well, we are looking at every component of the pathway. So if you start at the beginning, some people, as colleagues have described, really want an assessment. It's a really important part of the pathway for them. Other people might want the support, they might not want the assessment. That's their choice. If you can provide some of the support, you may see a drop in demand for assessment, and there is some evidence that's true in some of the early This Is Me pilot areas, because if people get the support they want, they then don't feel the need to have an assessment. If they do, fine. But that helps us to manage numbers. You've then got the services you buy in terms of assessment. In ADHD, there is then a follow-up treatment and medication regime, and there are options for how that's provided. There are parts of Kent and Medway where that's done by GPs. There are parts where it isn't under shared care arrangements. And we're looking at how we might widen the use of general practice prescribing and the handover of those who are stable on medication into those shared care arrangements with their own GP, which actually does allow for some of the holistic care that people have been talking about, because GPs obviously have that role for every individual.
Thank you, Ed. So the National Review notes diagnosis increasingly isn't followed by treatment. Like didn't have it for adults, but conversion to prescribing has roughly halved in children post-pandemic. Does the ICB hold data on assessment to treatment conversion by providers that we have, and how much are we paying for assessment that lead to nowhere clinically? If you understood what I said there.
So Kate may want to add, there's difference here between autism assessment and ADHD assessment. There's no medication associated with autism assessment.
So in the context
but in ADHD there sometimes is, and that is a clinical decision for the clinician making the assessment and for whom the person is being cared.
So I'll give you one more. Have you got one more to come in?
Yeah, okay. So yeah, the next question is really just around about, so obviously the ICB believes support should not depend on diagnosis. What practical support will be available tomorrow for adults, residents who are now expecting to wait longer in the community?
So there's support available from a number of different sources. Some people may get their support. So at one end of the spectrum, people may get mental health support, people may get support through a peer group, They may get support through joining in activities that aren't necessarily specifically to their condition, but are part of helping them feel better about who they are. So there are a number of different non-medical means of support.
So has there been like an increase in like investment within those support services, knowing that there's going to be a longer waiting list for some people?
So those support services are usually non-medical. They are not commissioned by us.
No.
There has been investment in the This Is Me part for children, which is a shared responsibility.
But not for adults, no. No. Okay, thanks.
Thank you very much, Councillor Shocker. I've got Councillor Brown, then Councillor Campbell to finish. Can we just stick to questions, please? We've already gone 55 minutes, so the questions, please. I'll still be coming back to Councillor Croft-Scott and Councillor Mandrakis to end. Councillor Brown.
Sorry, I've got a couple of questions, and I may be out of order in some of them, because I thought I heard that you don't know how many people are possibly on different waiting lists with different providers. Surely with an overspend of 23.5 million in last year, nearly 24 million, an exercise should be done to find out that, and if so, is it happening, and when will it be completed? And when can you hope to do some budgeting that's more accurate than a sort of 6 times overspend?
So the answer to your question is yes, there is an exercise underway. There are slight limitations around the way in which data is recorded, which can be in multiple places in the way data is collected. And there are some limitations around what data some contracts provide, some other providers, particularly where we haven't contracted them directly, to share with us. So we are in the middle of doing that. My experience of conversations with most of the providers, they want to have a relationship where we, they understand what we need from them and vice versa, and they're there for the right reasons. And that's exactly what we are building on in a data collection exercise right now.
And do you know how much of this overspend that you are having, even in relatively rough terms, is for adult provision, and in maybe percentage terms, roughly?
So in the right to choose sector, it is more adult spend. As far as I recall, well, we can provide a bit more detail in writing if the committee would like it. Don't have the numbers right in front of me. The statutory sector is mostly children, so it depends on which budget you're talking about. But we can send a few numbers afterwards if that would help.
I think that might be helpful, because the numbers that are provided are the
aggregate
total number.
Before I go to Councillor Campbell, Ed, you did tell us the percentage of adult and children in this contract, didn't you? Was it 73%? Was it children? What was the mix between the two?
Overall, it's just over half children. 55-45 was the last estimate we made. But the trouble is that it's about the number of unique. The difficulty at the moment is about the number of unique individuals on waiting lists, because people might be with more than one provider. They may also be with a provider for more than one assessment. So you might find someone's on multiple lists. That's what we're trying to deconflict, so we can be super clear.
Thank you. Councillor Campbell, questions, please?
Thank you, Chair. I'll try and be very brief. Ed and Kate, I have to be honest with you. I'm not following your reasoning. The way you've described IAPs, I don't see how that can be. You want the treatment to be and the diagnosis to be quantified and measured and standardized. You're going to reduce the number of assessments and the service you have. I'm not following the reasoning how you can do that without actually reducing the service you're giving. The whole discussion reminds me of our conversation about dentistry services, where you buy a specific number of units of service from providers, and that's the cap. That's X number of dental service units is what you have. And the reality of that is we have, for example, looked after children who've not had any dental treatment for years. I remember that came to our committee. So from what you're describing here, and do correct me if my understanding is wrong, you want to quantify how many people are seen and assessed for autism ADHD. You have a limited budget, a very specific number. You have a limited number of providers who provide this, and you're working backwards from these limitations. So that's got to mean that you're going to cap at whatever the number is, how you decide, maybe based on current numbers. My question to you is, can you reassure us, how do you reassure us that we're not going to end up with this situation that's happening with dental services, that you're purchasing units of services and then that is just not in relation to the need for it, but based on your budgets? The whole report to me was not patient-centric, I'm sorry to say. I read the report, you've taken pains to set out what numbers you have, but it wasn't patient-centric to me. Thank you.
I think it's really important to remember that whilst we all would wish to be able to provide as many assessments as people want, we do have to be very mindful that our budget covers more conditions. So we have to attempt to provide reasonable access across a very large range of healthcare conditions. And IAPs, where we say to a provider, this is the amount of this we are expecting you to provide for us this year, are not a hard cap, but they are an indication that that's how much we expect to buy, because we have to make sure that we are buying hopefully adequate amounts for a large number of conditions. Now, sometimes, as in this case, where we've seen that the demand has gone up very, very quickly, we know that this is a problem and that people are waiting a long time. And we've been very honest about that. None of us would like the waits to be as long as they are, but we do need to try and balance out demand across a very large range of healthcare conditions.
And I just add, the I in IAP indicative is to allow for a sensible discussion about things that change. So, for example, if a provider has on its referral list a larger number of people who need an urgent assessment by clinical recommendation than the IAP suggests they could see quickly, then we'll have a conversation with them and that will be altered accordingly, because there's no intention here to get in the way at all of those who need an urgent assessment getting one. That would always be facilitated. This is about managing those who've not clinically been deemed to need an urgent assessment. I know, and I understand why they want one, and I understand how important it is to them, but it's about managing the whole list, the whole waiting list.
Thank you. Could you address my point about the comparison with what's happening with the dental services situation? Because I'm basically just challenging your repeated assertions, Ed, that the service will not reduce, the number of assessments will not reduce. Are you absolutely sure that's going to happen? Because you're going to have to set a cap, right? Look, I have complete empathy with budgetary concerns. Honestly, I'm not kind of living in cuckoo land. I understand finite resources and increasing demand. I completely understand that. I just feel like we need to have a completely honest conversation about this and really consider what we're saying and the effect on patients. And I guess that's what was missing in the report for me, the actual true impact. And you've heard several examples here. But I do understand budgetary concerns. I get that.
Just briefly, please.
Yeah, I don't think the parallel to dentistry is obvious to me. But I think what I would say, the point I was making about the increase in spend and the increase in volume of assessments is that over the last few years, the volume has increased significantly, and that's mirrored in the spend. The thing we are doing in describing IAPs, which we did last year as well, and requiring providers to live within them, is to try and strike the right balance between speed of access and affordability and people's right to choose where they go for their assessment. That does mean for some people they won't be seen in a particular year, and that we just need to be straightforward about that. That's why we thought it was really important that providers communicated with those that are on their list to give them an idea of what was likely for them. And it has to be the provider that does that. So it is true that not everyone will be seen this year, and that the IAP mechanism is managing the volume of delivery in the sector. But I think I've explained why that is today.
Thank you, Councillor Campbell. Thank you, Ed. Councillor Mandarakis, before I go to Councillor Scott for just brief comments, please. When you things to you.
I'll try and be quite brief, but I wanted to drill down a little bit into what has already come up around the comorbidities around autism and mental health concerns and actually suicide. Because we're talking about if a mental health provider was to say, oh, I think this might actually be because of autism, they'd be referred in. But actually there's a 2-year waiting list to get on CAMHS. So you are already managing this wait list, and then somebody identifies that this person has a mental health issue, they start that referral, and that's a 2-year waiting list anyway. So before they can move up the clinical prioritisation because of their mental health, they've still got to wait 2 years. I don't think it works. And I agree, it's not patient-centred. It is purely about budgets. And I think particularly children, but actually adults who are waiting as well, will die whilst they wait. I genuinely think it is that serious. I've spoke about my own personal experience as well with my son, where he was first referred in year 2, then diagnosed with ADHD in year 4. And at both of those points, the school were pushing for it. And I was like, as a parent, I don't see the need, but if he's having issues at school, I'll go along this road with them. Was not that bothered. He's now in the year 6 to year 7 transition and actually is starting to struggle with his mental health. Now, he has that diagnosis behind him and can push for support, but if he didn't, where would we go? How would we access that? How would he get pushed up any waiting list when, like I said, there's a 2-year waiting list for that mental health support that he now needs?
Hold that answer, Ed. Councillor Scott.
Yes, thank you. I am concerned, and I'm bringing in on what Councillor Golvin said. Yesterday I had a call from a family in Medway. They adopted a child when he was 6. He's now 14 and he's really struggling. They're not getting the help that they need, so they've written to their local MP, but also to the Children's Commissioner. You know, my visits in youth custody and prisons show me that most of those people are on the ND spectrum. So we might be saving a few pennies for the NHS, but we're costing a lifetime of support. Early intervention matters. And my saddest and most poignant plead is, please, it's the drive for equitable access to services. You know, I have illiterate constituents. They sometimes are vulnerable and they can't push for their own children. Yet, as a parent, I've been able to push for my foster children, and it just doesn't seem to be a level playing field, and that has got to change because no child's worth is greater than another's, in my opinion.
Thank you, Councillor Scott. Ed, any comment about Councillor Mandarakis from Kate or that around the suicide
I might ask
stuff?
Kate to answer the first
suicide
question
one,
because it's a clinical one.
So just to address the level playing field, it is precisely because we want to level the playing field that we're trying to make sure that everybody is assessed in the same way.
If you can just talk into the mic. Sorry, every time you turn, we can't hear.
We want to make sure that everybody on a waiting list is offered the same clinical assessment. Because I agree with you, it's very important that people who don't have as much advocacy for themselves are getting the same level of assessment as other people. In terms of comorbidities, obviously a referral in for mental health support or an assessment will start with someone's GP. So if the GP is referring a child in for mental health support but thinks there might also be a problem with neurodiversity, they can make the 2 referrals at the same time. They don't have to be sequential.
So at one point we did speak to our GP about mental health. At that point in time, like I said, we were on a pathway, but I was not concerned about the autism. I was concerned about the mental health. The GP would not have picked up that that might have been because of neurodivergency. I went to the GP saying, I'll just say, he was asking Alexa what is depression and all those kind of things. So it was relatively, compared to other people's stories, and he was only in year 4, so it was relatively low level. But like I said, I didn't think that that was connected to his autism because I didn't know about it. So how would the GP have known that that wasn't a normal CAMHS referral? Well, not even CAMHS at that point, just a normal mental health referral.
Just briefly, Kate.
Yeah, so I'm very sorry to hear about your experience, but I don't want to discuss an individual experience here. It's part of the assessment that a GP would make of a child. And it's actually, as Ed has mentioned, very important that we try and keep much of this stewarded by the GP at the centre of it, because they are better able to make holistic assessments, because they have a longer term relationship with the family in many cases. So a GP looking at a child with depression would know clinically to think about if there might be some other comorbidity in there as well.
Okay, I think before I just got a couple to because you're lucky because I asked quite a few at the children's one, which Joe allowed me to. Leanne from Healthwatch, what's Healthwatch doing on all of this? This is a really important subject. What's Healthwatch doing in Medway and on this in the Medway towns? Could you let us know?
Yeah, so we recently did a report on people's experiences of ADHD services in Kent and Medway. Yeah, we heard a number of different things. There was, I think one of the biggest things that we heard was that people were concerned they weren't getting that support in the interim period before receiving that formal diagnosis. There was quite a bit on the right to choose pathway as well. I don't know if you've seen the report. Have you guys seen the report that we've mentioned?
I don't think any members seen it, Leanne. Did you send it to members? I don't think any of us have seen the report. That's why I think that's why I'm asking the question about Healthwatch, and specifically for Medway, not Kent, for Medway tonight.
Yeah.
What was the outcomes in Medway? That's why I think we need to. It'd be really good to know what like if you sent it to members. You don't have to go through it all now,
Yeah,
but it's key.
We did. I think we did send it out. I can send it out again. It was a Healthwatch Kent and Healthwatch Medway piece, but there will definitely be stuff in there relating to Medway. But I can send it round.
Thanks, Leanne. Yeah. Thank you. Ed, it's just a couple of quick from me. Isn't the reality that the NHS has run out of affordable capacity and is now rationing access by another name? Because the ICB are in trouble financially. So, is it the case that we are now, you've run out of affordable capacity? I know you keep saying nothing's changing, but the approach is changing.
Well, I said the various things haven't changed. It's very, very clear that we have described IAPs for our providers that define a volume of service they're going to provide. I think that's a reasonable thing to do for a public organisation spending public money and living within a budget, having to make quite a lot of difficult decisions across a set of services as Kate described. So we're trying to triangulate lots of things to do that in the best way possible. We can't, there are lots of services where there is a waiting list, particularly post-COVID, where people didn't get seen in the way they would have done normally. And lots of people are waiting longer than everyone would like still, which we are trying to bring down over time. So we're trying to do that in the best possible way and make the best possible set of decisions across the board. I would say that we have increased the spending in this area. If you were to look at it proportionately, there are very few other things that have grown anything like this. So I just want that to be clear to everybody.
I think, but should patients now wait longer because commissioners failed to anticipate demand and control expenditure? Well, you've heard tonight, I know we keep saying we're spending more money in there, but it's not just about throwing money at something, it's about doing it in an effective way, isn't it? And helping, and you've heard from so many people. It's not for you to go off or Kate, but you've heard from so many people about the joined up approach, how it works better and how it could work better, and how you can save money in the future. I think you can understand why members, because Ed, my final bit is, you can't sit, if I asked you, and I said to you tonight, how many Medway residents will wait now longer specifically because of the introductions of these activity limits? You can't guarantee that Medway residents are not going to wait longer, can you, because of the activity limits that you're going to introduce, can you? You can't say they're not going to wait longer now, it's going to be quicker, can you?
Well, longer than what is the question? Well, because they were always going to be
they're long
IAPs.
now. Yeah, so they're long now, but whatever in ICB terms you call longer. I mean, if the waiting list is long now, are Medway residents going to be waiting longer than what your current activity limit is because of this change in approach, or because of these changes you're making with your providers? You can't sit. I wouldn't put you on the spot and say, are you going to promise me Medway residents will not wait longer specifically because of this new activity limit you're introducing? You can't say that unless you want to, but you won't be here for you won't be here for the HASC in
Well, so
6
the answer
months'
to how
time.
long someone will wait will be based on the clinical priority they have in the waiting list. And that is the right principle. I hope everybody agrees. That's the right principle in the order in which to see people. We are doing a number of things around the pathway in terms of support that might mean fewer people want an assessment. Others still may want one. We are working with the council, for example, on This Is Me. I know largely focused on children, so not really for tonight, but there is partnership working going on. And I think you're right in the sense that in neurodiversity service provision, there are lots of things which require both the NHS, local government and others to work together to get it right. There is definitely, I think, a sign here that we need to do more of that. I think it's also important to say the things that NHS Kent and Medway are working to try and solve are the same things that every ICB in every part of the country is trying to do the same to solve. So it isn't that we are experiencing something that we haven't planned for that everyone else has got right. This is a significant change in the way that people are presenting for for assessment.
But don't you get it, Ed? That, I mean, I know you do get it, but I've got to say it. You've got members. Sorry, guys. You've got members around the table that keep asking, and it's not that you're dodging the question because you've answered the questions tonight. I know you both have. But you've got members keep asking about specific parts of this of this change. Specific, are people getting that better pathway? Are they going to be getting that better service? Is the GP going to be joined up? They're asking, and you had this at children as well. People kept asking about how is it going to change, and it doesn't seem anything. I know it's on the paper.
As an example, we are going to be expanding this.
I know you are, but again, you don't have to answer this one. But people keep asking us that people get confused by it, I think. And like at the children's one, I know Councillor Bovo asked about data. Councillor Campbell tonight has said about data. Everyone asked about data as well, but I think it's just about the clarity. We hope as a committee, I suppose, that this isn't going to be detrimental for the children and for the adults waiting on this service, but I'm not confident that it's not going to be detrimental to them. There is one more question, members. Ed, I'm going to throw this question. I know what you're going to say to me. There is one thing for members to decide tonight. I've had a few members ask me about whether this should be an SV, Ed, about whether there should be a substantial variation. I know not a pushback, because you always talk to us about it. No one should ever be scared of a substantial variation. But I know that it was about, because it's a change, you haven't reduced service, you haven't reduced the funding, that it shouldn't be an SV. I would push back on that and say, well, your approach is now changing, so maybe the committee would want to keep an eye on it. I suppose, Ed, do you want to come in first? And I've got to ask members, because members have asked me whether I should present an SV tonight for them to vote on.
Well, so what we've done is apply the standard terms of the NHS standard contract, which we are obliged to use in commissioning, in the same way as we apply to a lot of other services. We did that last year. So
we done a load of SVs on you last year as well, didn't we? But I think, Terry, do you want to come in?
Yeah, just to clarify, members don't need an SV to be able to ask the IC back for updates either. There's still a statutory responsibility for all NHS providers and commissioners to come to the committee as you request. So you don't need that SV status to be able to do that.
And to be clear, normally I'm the one that's pushing for the SV and coming straight out with it, members. But I've been asked by members whether there should be. Are we contemplating? Members, does anyone want to come in? Councillor White, let me ask the spokes, or Councillor Perfect, what your comments are.
I'm struggling because I can't see the harm in an SV, because it makes it more public, brings it out in, etc., etc. But a service that's increased the level of what they are actually doing, and it seems to me that what you're doing is making it more in the public, so more people are coming forward for help. I'm not sure of the benefit of an SV. Now, I'm the first one when I think you're failing, and I think you're failing children and have been for the last 20 years. But in the adult services, you're increasing what you're doing and doing the best you can in the circumstances. So I would support an SV if everybody else goes that way, but personally, I wouldn't push for it.
Terry?
Thank you. Sorry, the other thing members need to understand with an SV is when there's a substantial variation, normally that's about a change in a service, and then if there is an SV that is agreed that there's an SV, then the commissioner or the provider has to do two things. They have to tell us the date by which they want our comments on a proposal, and that's published, and they also have to tell us the date by which they want to make a decision. And again, that is published so that that's publicly available, that the public can see what those timescales are, and that the committee are clear about what their timescales are. I don't want to suggest either an SV or not. That's for members to determine. But I suppose what I'm saying is, I'm not really clear what timescales the ICB would be able to give you, because they're not necessarily that there is an approach here, and they're being more open around so that people are being given timescales and expectations. But I think what the ICB would probably say, feel free to nod or shake your head, is that they wouldn't be able to give you those timescales in terms of when they would want our comments on the change.
Yeah, but I think they would have to come back at some point. But thank you, Terry. I think on Councillor Perfect first, I'll come back to you.
Yeah, thank you, Chair. I mean, I agree with Councillor Wilde. I mean, my other broad point is I am growing a little bit concerned about the amount of SVs that we're doing with the ICB. And the other concern that I generally have is, obviously, we've got the draft commissioning intentions here that we're going to be discussing shortly. Yeah, I'm hesitant for us calling because the ICB, obviously, as I think I said last week at Children's, have got this huge budget gap. They're going to be doing more of this. We're going to be having this constantly, in my opinion. We're going to have decisions every 5 minutes that this committee is going to find contentious. My concern about us constantly calling SVs is that we're going to get to a position where effectively those SVs become watered down and aren't taken as seriously if we're SVing every single thing that they do in order to get that budget gap down. So that would be my only other observation to the committee. I'm just growing, and if we at any point feel that we need to escalate things to the Secretary of State, if we've then been issuing SVs on pretty much everything the ICB is doing, I think it could, I think it might harm the case. So that would be the only observation. But I do note, the significant concerns and lived experience that colleagues have been sharing this evening, which I think the ICB does need to take note of. Thank you.
I think you're right, Councillor Perfect. Although I must say, I think on the SVs we did before, obviously some were set, most of them were seconded by yourselves and even asked for by you guys as well. So I think we try not to water them down. They were key, serious issues we were dealing with last year. So I do agree. One more contribution around the comments to me about SV. I mean, I'm not pushing the SV because, well, like I say, we can call the ICB back at every single...
So I'm also of the view that we shouldn't call for an SV on this, purely because I just don't see it making any tangible difference. I just don't feel it will have that weight that we want.
We've done the debate for you, Ed and Kate, so you're okay. So I'm not going to be calling for an SV tonight, everyone. Okay, Vice Chair, please.
So I've got the note that this committee is requesting the ICB to reconsider the categorization of children for the assessment of autism and ADHD and move looked after children from category 2A to category 1. I move that the committee notes the update from the NHS Kent and Medway Integrated Care Board as set out at Appendix 1 to the report and the draft minutes from Children and Young People Overview and Scrutiny Committee, which has been set out in an addendum report.
Is that seconded? Yeah.
Just on that conversation, I totally understand what you're saying about the SV. If we don't have a recommendation that we're going to revisit this discussion at a certain time, will it come back automatically, or do we need to add a recommendation that we're going to talk about it again? Thank you.
We can definitely ask for it to come back. We have pre-agenda. We can make sure it comes back. I mean, you want to see how it's working through, but if the committee decides that you want it to come back at a regular period, then there's nothing stopping this committee for calling the ICB always operate with us on that. They would come back whenever we wanted that information. Ed, you wanted to add something to our recommendation, maybe?
Well, can I just ask on the clinical prioritisation criteria? I have no issue with the clinicians being asked to look again at the criteria. I do think it's tricky for non-clinicians to tell a clinician what the clinical prioritisation criteria ought to be, I wouldn't do it. And I'm the Chief Commissioner in the ICB. So I just think if we could frame it in a way where we ask them to think again about whether it's right, I think that would be more appropriate.
I need a clear recommendation.
Go on.
So I'm happy, perhaps if we word it in a way where the clinicians developing this criteria are asked to ensure that looked after children are, that status, it kind of emphasises their priority along with the other clinical stuff, something along those lines.
I do think we need to look at what the members are asking is about the 2A down to 1, and whether how we word that or how we look at that pathway is fine. I think that's where you are right. I think we just look at it like that, but happy to go on, Councillor
I did use the word reconsider. I don't think we are demanding, so I actually feel that was appropriate, but happy to go with what Ted.
Thank you. So have I got a seconder on that now? Seconder? Yep. Okay. And agreed, members? Agreed. And can I just thank Councillor Scott and Councillor Mandarakis for coming? Really, really important, including your lived experience. And can I also, again, members, just thank Councillor Cook. This isn't the first time you've told us about your lived experience, and it was hard the last time too. And it does help members really engage their minds. So thank you, Councillor Cook, for what you do as well. And yeah, we've had it for yourself, Councillor Jackson, and for Councillor Mandarakis. I've said it to Councillor Jackson many times about the other elements we talk about, but them lived experiences are key for this committee, and I don't want any member ever not to be able to say how they feel about things. I'm going to do a 5-minute break, members, and then come back. You're straight back, and we're 5 minutes max, and then we're coming straight back, and we're going to be tighter on the next items, please. back to our meeting now. So we're moving on to item 6, Commission intentions. Councillor Wiley, you want to come in? We've spoken, us two, so do you want to come in with a suggestion?
Well, thank you. I was going to recommend that personally, I haven't had these papers long enough to take them all in. There's an awful lot of them. They came to me without much time to read them. I've already got 2.5 pages of questions. If every member's got that level of questions, I don't think this will be a very productive meeting. So I suggest that we take it away from here and have a briefing from Ed or the team that will be most most helpful to us, or an online meeting, whichever's considered best. Give us all time to consider your questions, which I do find strange that you're asking us questions, but it is our scrutiny. But if that's seen as a way forward.
So just to be clear, I think Ed and Kate, because you're here, we will let you introduce the item, obviously. Again, like Councillor Wiley, I've got about 3 pages of stuff that I could feed back, as I'm sure you're aware. What we're saying is, though, but Councillor Wiley, to be clear, I agree with you. I think it'd be too. It's not. HASC isn't really a consultation. It's not for us to feed back loads of comments. So I think it would have to be a very. You've got the report from the ICB because it's in our pack. It's very clear, and I think once we clarify the closing date, the officers are sending. David is sending his one through, anyway. And if any members around this table want to send any comments, send them to Terry. But we need a deadline, and obviously once it's the end of next week. But the sooner the better. If anyone's got any major things they want to send through, send them through to Terry. And I think that makes this item a lot easier for us and for yourselves. But obviously to open, if you want to just open anyway, and just to make sure members are not worried, because you did have 8 never events and things like that. It's just about anything that you feel you might want to bring up that members might want to know without the questioning of members, because if our members agreed that we do that by Terry, is that agreed by members? Just to get it clear from him start. Okay. Ed, do you want to just introduce him, Kate?
I'll be brief then for everybody's time. So the idea of the commissioning intentions is they're published well ahead of next financial year, so that we have time to get feedback on whether they're the right thing to be changing about the health system, whether we've identified the issues we're trying to address in the right way, whether we found the right solutions, whether people think they're implementable. We're doing it such that we publish them at the end of July. That's when they went out. We will approve them at the end of September as an ICB board, and then those turn into letters to the providers about what we intend to buy from them the following year. So everyone has lots of run-in to change services appropriately. The idea is it's consultative. I think for HASC, part of the reason we wanted to make sure you were engaged in it is we have, I think, run up against things where you haven't had foresight of what we are planning, and we wanted to make sure that we were in a different mode. We want to be in a different mode for a variety of other reasons, but that's one of the reasons that we were doing it, and we wanted you to know it was there. I think it's less for scrutiny and more for feedback at this point, because we haven't made a final decision. These are drafts. So anything you've got to say, or anything those you represent have got to say, because we thought in many ways you were a conduit out to the people of Medway and have an interest in health and care. That's what we want to hear.
So that's what I think members should do, members of HASC and wider even, across the whole council really. But for HASC, I think if we're clear and if members can send stuff in, that'd be really good to Terry, especially things that they feel are really important from the intentions. I think that's, I mean, the one thing I would say is that, again, whoever's here in your places after, what I want to be clear is those that, I know you're giving it up front tonight, which is really good and really helpful for HASC, and I appreciate that. But obviously, the unequivocal commitment has to be is that if you're going to make any major service changes, we do know about it. If it'd be really good if it's presented to us before all of a sudden we hear about it afterwards. I think we've gone through that, and I think that that is definitely in the system now. I think Adam and everyone's has got that in the system about all of your team letting us know if something is going to majorly change.
Sorry. I just want to manage expectations. 2.5 pages of questions. Just there will be a capacity issue if everyone's sending me 2.5-page questions. If it's feedback for the ICB to consider before they finalise that, that's absolutely fine. But just to be clear.
And just for I bring Councillor Perfect, and I'm just saying, if members are happy, Terry does an amazing job. I think if there's repeated stuff that comes back, Terry can just summarise that and just send it, and I can always check it and with Terry as well. Councillor Perfect.
Yeah, I was just going to say, obviously, we're also going to be making, obviously, Councillor Wildy, Councillor Joy and I will write as leader of the opposition, and the relevant shadow cabinet members will be writing to the ICB anyway. So, I mean, I'm happy for us to, there'll be some central things I'm happy for the council to pick up through that, but I'm sure we can pick up most of those questions separately and in the regular engagement that Councillor Wildy and I have with the Chief Executive. Thanks.
And it's good if Councillor Wildy wants to send me, we can match it up from the ops spokes even, we can do something, so we can just do something there. Thank you, Ed. Thank you, Kate. And Chair, Vice Chair.
So we've agreed that we'll remove this particular item from this agenda, and all members are encouraged to send their feedback to Terry by the end of next week, and which can be condensed and sent to the ICB. And then, if required, we can have a separate meeting for the members or call back to committee as required.
Yeah,
I don't think we need a set unless the ICB feel that, because we can call the ICB always attend our HASC anyway.
Yeah, okay.
I think if Ed feels that once your intentions are agreed or whatever, once there is feedback and you want to have an offline development, like we do have our offline development sessions, then obviously you know that HASC would be happy to be part of that if that was there.
And the timetable is the last week of September is the board meeting at which we'd agree the final version. So that would reflect everyone's feedback, and then I'm happy to do whatever.
So, Vice Chair, Councillor Campbell, we can ask for, after that's been done and agreed, we can always ask for a session to come back here. That'd be great. Okay, we've agreed that. Yeah, okay. No, it's all right. I think we've done it. Seconded, members? Second, agreed. Can I just ask, please don't send pages and pages to Terry next Friday, because I would give Terry permission not to push them in. I think just because we've got it next Friday doesn't mean we have to do it then. Thank you so much, Ed and Kate, and I think you're still staying here again now for the item 7, the maternity review, and we've got Jenny joining us as well.
Jenny's going to introduce, though.
Welcome, Jenny, and introduce yourself to the committee as well, but also introduce the report.
Right. Sorry, I'm not very good at technology, which you've just seen. So just to introduce members, I'm Jenny Hall. I am the Chief Nursing Officer now for the ICB. I joined the ICB on the first round that we are proposing to do in the ICB. In the paper, the members will see that there are some drivers for that, principally around the AMOS report that was published very recently. Members will be aware that that report looked at 12 sites nationally, one of which was a site in Kent and Medway, which was East Kent NHS Foundation Trust. Within that process, 450 families were interviewed and 9,000 staff. It also was in response to the Donna Ockenden reports, which have been in a number of different settings nationally, and they have looked at where there have been concerns about services, and it has been an independent review of those services. So as an ICB, we clearly need to understand AMOS within this area, within the Medway area, and understand what it means for our maternity services. Members will also be aware that since the publication of AMOS, there have been a lot of initiatives from the Department of Health around an understanding of what all health services need to do to deliver in a different way. And that has been very much centred on providers of maternity services. You will see from the paper that we have not, in Kent and Medway, undertaken a maternity services transformation programme for a period of time. Also that within the Kent and Medway area, 3 out of 4 of our providers are in what we call enhanced support. What that basically means is there are enough concerns around the quality of services that are being provided, that external support is being brought in to support those teams and services, and it is immediate support rather than support in the future. You will see the approach we have taken was to initially develop some terms of reference with elements of that terms of reference not concluded. We took that to the board in July. The board agreed the principle of that being taken forward, and then we've had a second step where earlier this month we had a number of stakeholders in the room and they had an opportunity to shape the end of those terms of reference, and that was a very important point around stakeholders being able to understand what we were going to do in this transformation programme. And I should stress that there were maternity and neonatal voice partners in the room, meaning that we had the voices of women in the room, and that was a very important part of the process. We are at the moment just concluding the outcomes of that. There was a lot of passion in the room. All of the partners that we invited attended, and there was consensus that this work is the right way forward. We brought it to the committee tonight to invite comments on the scope and what we shared to the committee, and obviously for the committee to also ask for us to understand what updates the committee would like before we get to the step of a step where we're formally consulting on the changes that are proposed. So I hope that's helpful.
Thank you so much, Jenny. Members. Councillor Perfect.
Thank you, Chair. Thank you, Jenny, for your report, and congratulations on your new post, and welcome to Kent and Medway. Very pleased to see you here. I think you come very highly recommended, so welcome. Good to see you. I think from our perspective, I mean, I'm sure you're aware of some of the, I mean, you probably saw part of it in the previous conversation, but I think from our perspective, very good to see this at a very early stage, and also I think quite helpful for us also to see elements of the board papers included within this pack, which help us a bit more understand the decision making that the board made on this decision. I think from my perspective, I'd be very interested as this sort of progresses just to see from your side just more of that sort of engagement with stakeholders on the ground, I guess, that those sort of consultations you're talking about with the particularly some of the lived experience people that are accessing this service. So from my perspective, I think that would be good to see. But I think, as you referenced, it's been some time since this review has been undertaken into these services. So I think, you know, welcome at the timetable and the purpose and the scope. And thank you very much for bringing this to us at an early stage. Thank you, Chair.
Thank you. Jenny, anything to say?
Yeah, I mean, I think the importance of this is that we want to improve the quality of services. I think there's no getting away that the quality of services we're currently providing is not a status quo that anybody would want to defend or support. So we need to have the conversation. We need to involve people who have used the service in that conversation. And we also need to make sure that whatever design comes up, that we are going to do it in the right way. Now, there are going to be a range of views in the room. There will be some areas where people will agree, and there'll be some areas where people have differing views. But you will see in terms of the scope that we are starting at the acute layer. So for members, just to remind them that we're commissioning by 4 layers of care. Members may not have had a chance to read that within the commissioning attentions from the previous item. But what we're doing is the bottom layer is wanting to make sure services in primary care are working in the way we would want them to. Then the next layer up is about what we call neighbourhoods, which is populations of 30 to 50,000. Then multi-neighbourhoods, which are looking at larger populations and where we need to do services. And the top of that is acute. Where we're starting in terms of this particular review is at the acute layer. So getting that part of the service right is the priority. We then flow the elements through the other layers. So I hope that's answered your question.
Councillor Wiley.
Thank you. Probably less strategic, but reading these papers, excuse me, it sounds there's going to be less births in the hospital and more by midwives in their own homes. And if that's correct, how are you going to assure that that's as safe as possible? And I think I know the answer, but I would still like to hear it. And I'm still of the opinion, I mean, if I was to have grandchildren, they would be, I would be happier if they was born in the hospital, because if anything goes wrong, you've got hopefully everything there that you would need. How are you going to cover that, you know, with midwives?
So I think there's a very important point here. We've talked about choice. Women have a choice, and that is a very integral part of maternity care. Women will choose where they wish to go. We are not going to take that choice away, but we have to have an understanding of that choice in terms of the service discussions about what is right for a woman. Now, if you are a woman that has a maternity pathway that's very straightforward and wishes to give birth outside of a hospital setting, there will be some clinical decision making that will support if that's the right decision for them, if that's their choice. Midwives are highly trained. They will understand where there are clinical situations that they might need to advise a woman to go to hospital. Equally, if that woman is delivering at home and it is safe, then they will be able to manage it. So it is a triage process. By that I mean there is an assessment and then there is an understanding of where a woman needs to give birth. So that's quite a fundamental part of this. We have lots of maternity reviews that talk about what is good in terms of overall maternity care. One of the fundamental parts of it is making sure that women are well informed. If we do that, and we've got clinical care around that, delivering that care, then safety should not be an issue, depending on where the setting is. And as I've said, midwives are very trained to do it. So we will have speciality midwives in the community setting. We will have speciality midwives in the hospital setting. Does that answer your question?
It does, and I accept that in theory, but you know, within my family, there have been problems that were unexpected, etc. Yes, so things can go wrong, and yes, we have to be aware, or you have to be aware of that, and I'm sure you are, but just making the point that I think there can be concerns around that for anybody. But
Thanks, Councillor Wiley, and thank you, Jenny. Councillor Cook.
Yeah, thank you. Just an observation and a question. I think firstly to say the thing that really came across to me is almost the opposite to previous conversations around how patient-centric this felt, and I really appreciate that you've started with the kind of consultation piece and the voice of women. And I know we spoke about, I think, about a menopause item recently, and we were talking about, you know, how significant it is that the voice of women at every level are heard, and I've heard that again here, and that came across really strongly. I was also, and I really appreciate the decision we've just taken about the previous item, but it was very helpful to have that item in advance, because I could really see this as a kind of worked example of what you were saying around where you were going with the transformation. And I think the question is probably a meta one, which is what I'm going to send to Terry, but for this specifically, much like the other issues we've discussed this evening, this isn't an issue you can say to somebody, if you could just wait a few months and we'll see you then, you know, this has got to be dealt with in the moment. And it's how, with all the questions we have with HASC, it's how we manage transformation while still keeping quality of care now. And, you know, we can't suddenly have more people so that we can train these new people coming up here for the new way of doing when we're already pushed with the people that are working on the ground now. And I don't envy you that, as, you know, I can see where you want to get to, I can see where you are now. But how do you kind of assure us on behalf of Medway, if you like, that in the interim process of change, that there isn't going to be any, you know, that we're going to keep that real high level quality of care in the interim? Thank you.
I'm going to stress to the committee, the reality is we are not delivering high quality care right now. There are areas of really good practice, but there are areas of practice that need to change. That's the reality. We're not doing this because it's just a Kent and Medway thing. We're doing this because time after time, reviews have said that the quality of maternity care is not where any of us would like it to be. I think in terms of process, this is about understanding how the services need to be designed. That's about the hospital setting, if you remember to start with. So how do we make sure in the hospital acute setting we get it right? One of the national pushes around midwifery is making sure all the midwife students coming out are employed. That's been requested by the National CNO. We are working on that in Medway and in Kent. So that is happening now. This will not be a sudden shift. This will be a shift over a period of time. And I think that's really important for members to understand. We've got to do this in a safe way. Because we're not doing things in a safe way now, some things are going to have to move a bit more quickly, other things will take a little bit of time. And if you take it from the perspective of a member of your family receiving care in a setting where all of us know it can be improved, I think that is a catalyst to say we need to do things. So that's where we'll come from. And I think it will also give us the opportunity to then say, how do we start to think about the other layers and how do we start to prepare? Because training is not a two-day thing. Training is over a period of time. And already nationally conversations are different about how we train people for future healthcare delivery. So that's already happening. That isn't about Kent and Medway again, but there are lots of things coming together that say, actually, this is the right way forward and this is how we'll manage it. Does that answer your question?
Thank you, Jenny. Councillor Garvin, if we just questions, if we just stick to questions, members, because we've still got another 5 items on your agenda.
Thank you, Chair. Yes, I'd just like to say I think the most important aspect of this is to listen to the mothers. I've been blessed. I have now got 4 great grandchildren. Both my granddaughter and my granddaughter-in-law both had tricky birthing experiences, and both of them commented to my wife and I that they felt they weren't listened to during that process, and that seems to be a sort of thread that's running through a lot of this, and what I've seen on reports in the media as well. The mothers feel they're not listened to, and I think it's got to be mother focus, please.
And it will be. And I think the other thing to say is that one of the findings from the Amos report is someone named Martha. It's really clear, and it has been requested, that anybody coming into a maternity service, you listen to the woman, you listen to their families. And when they're raising concerns, that's when a service needs to act. So it's already changing. I'm sorry to hear perhaps their experience was not better, but actually this is where we can get the voices of the women to say, my experience is, and we want to work in a different way. And I should also say this is about people who may be experiencing deprivation. So it's about making sure we get those voices right across the communities.
Thank you, Jen. Leanne?
Yeah, again, I just wanted to comment on the fact that people being involved from the very start. I think that's really good. Health Watch Medway are currently working on a project about discrimination and health inequalities. As part of that engagement, we spoke to a number of different people from different ethnicities, and there were a few black mothers who recounted their poor experiences using maternity services. So it's just a question about how representative are the voices that you've got in that co-production, in that consultation, just to consider that, yeah, all voices need to be represented to make sure that it's inclusive and equitable.
Completely agree. I think it's fair to say we are at the beginning of the process. So we invited representatives to be nominated. Into that process they came. I think the reality is that we will have to be quite proactive in going to different communities to make sure their voices are heard. And that was very clearly learnt from the last few years, particularly during the COVID period. So I think we need to make sure that happens, very aware that there are different experiences. So we want to make sure that we can hear those voices, but also then shape services in the future.
Thank you very much, Leanne. I think for me, Jenny, it's really good to hear about being, listened to. I think that national report, the review was really informative, and I've seen it so many times over the years, mothers not being listened to, not being heard, not having their voices heard. And sometimes you think to yourself, don't you, how many times must maternity services hear the same findings to change the culture? Because it just tends, if you look at it, it's just a pattern every time, and hopefully this time round it will change. But coming more locally now with you, 3 out of the 4 maternity providers required enhanced oversight is not a minor concern, is it? It's a serious concern. Would you say the ICB are satisfied? It's a really difficult one. Are you satisfied that maternity services across Kent, and especially not for us, Medway, are safe tonight? Would you say they are, yes or no?
I don't think I can give a direct answer to that. I'm not going to sit here and give a direct answer. I think it's really important, and I had a meeting with midwives yesterday. It's really important that in all of this, we don't go away with the impression that nobody cares. There are an awful lot of people trying to do a very good job. And there are aspects of services that will be good. It's not about all those aspects of the services not working, because if we were in that space, the service wouldn't be open. We're not in that space. I think this is about consistent quality. I think this is about, as we've heard, listening to the experiences of women and being able to respond to those experiences in the right way. So I can't give a yes or no answer. I know you weren't expecting it, but I think we cannot sit here and give that assurance tonight.
I don't expect I wasn't expecting the assurance, I suppose, but, I do understand what you're saying, but, mothers do want a safe service. And from a quality aspect, it's all right, you come back in a minute, from a quality aspect, that is the role, isn't it, of the ICB? And, there are some amazing midwives out there, and it's a shame just recently they're getting some really bad, because there are some amazing ones. I know Medway have won awards over the years, and there's some really good. But obviously, your role is around that quality and the care and making sure it's safe. It's not for you, Jenny. I know going home tonight worrying about whether anywhere is safe or not, but it's a question you'd expect to hear from us. I think my question on from that, though, for you is, if clinical evidence says to you over the next few months that the safest option costs more, if we have to change, safety obviously will come above savings, wouldn't it, for the ICB? You've got to look at safety above savings when it comes to a service change.
So just your initial point around safety, I think it's really important to say that we have a lot of mechanisms by which we have oversight of services. And those mechanisms, if there's a particular concern, we're aware of them, and we work with other colleagues to deal with them. I think in terms of your second point, this is about delivering the right service transformation. The right service transformation doesn't necessarily cost more. And actually, costs can come from delivery of poor care. So I think this is about trying to deliver to a standard of care. It may be cost neutral, it may cost slightly more, but it's about collectively achieving that standard that we want to do.
The standard, obviously, is keeping people safe. Keeping people safe. That's the priority across the whole service of the ICB, isn't it? Not just maternity, but that's a good thing to hear. Is that hopefully this? And I totally agree with you. It's not all about the changing the service in the best. Sometimes you can change it and it costs less. I think that's what we said earlier. Vice Chair, you want to come in with something, Councillor?
Are we agreed on the further briefings, regular briefings that's mentioned? Okay.
Yeah. Vice Chair recommendations. Thank you. Thank you, Jenny.
Shall I read it? Yeah. The committee notes the purpose, scope and timetable of the maternity services review as set out in this report
And it notes that the ICB board approved the agreed elements of the review's terms of reference on 21st July 2026 and delegated final sign-off of the complete terms of reference to the ICB chair in consultation with the chief executive following further engagement and co-design through August 2026. The committee confirms its wishes to receive further updates as the review progresses, informally via briefing notes until any future recommendation involving any potential change to how services are configured when the committee's formal role in the statutory consultation process would apply.
Is that seconded, members? Seconded? Agreed? Agreed. Thank you so much, Jenny. You know, please be reassured. It is something that we feel strongly as you about, and it sounds like, you know, it's in good hands under your leadership at the moment going forward. I think that's great. And when we ask for updates, it's because we genuinely want to hear those changes and hopefully changes for the better. So thank you very much for your time tonight. Can't believe that Ed and Kate went through the whole item without saying one word. It's good. That's how you like it, isn't it? Okay, can we move on? Thank you so much, Jenny. Thank you. Can I move on to item 8, the mental health review? Keeping as the paper read, please. If you wanted to do a very quick presentation on the beginning, a quick highlight, please.
To undertake a comprehensive review of the commissioning of mental health and disability and autism services. We have written to a variety of stakeholders with our draft terms of reference, and we have started to get feedback from various quarters, including from officers of the council. So we wanted just to flag our intention to the committee so that you can see what the plan is. You may have views about what it should cover. We touched on it when we did the children's meeting last week around ADHD and the connection between mental health services and autism and ADHD assessment services, for example. And we'd happily receive any feedback offline if that's easier. If I know it's late and you've got a lot to talk about.
So I think you've taken plenty of comments back from the ADHD stuff earlier, haven't you? So you've got plenty on that. Members, anything on this item for Ed and Kate? Councillor Wildy.
Just, I think the obvious question, on the ADHD and autism, you're putting more funds into it. And will this review be intended to be a cost-cutting exercise or to improve the services? And that's a leading question because I hope for the right answer.
No, the review's not a cost-cutting exercise. The review is our commitment to make sure that we offer the best possible care that we can across mental health and learning disability services. So that's our motivation for undertaking the review.
Okay, thank you.
I mean, if you were to benchmark our spend, it might be sensible for us to be spending more in mental health. And we have a spending framework for mental health where the ICB has to meet something called the Mental Health Investment Standard, which is a minimum investment level in mental health services. So I hope that's reassuring too.
Okay, thank you.
Thank you, Councillor Wildy. And I suppose, Ed, I mean, we've got Sheila coming up in a moment, but obviously the KMMH will feed into that review, I'm sure. I can see Sheila nodding her head there, so I'm sure they'll be feeding in about whether they want you to spend more money on mental health. But go on, Ed, you can come back.
That's definitely right. But I think one of the things we want to do in this review is be really clear about all of the components of the pathway, what the voluntary sector does, what doesn't get done in our specialist mental health provider, and the connections between all of those things. So obviously Sheila and team will play a big role as they should, but it is much wider than that.
Oh no, I was saying it wasn't definitely more money for them. It is about the voluntary sector as well, and many of us here would that be music to our ears from that. So, okay. Vice Chair.
I move that the committee notes the ICB submission, including the information set out at Appendices 1 and 2 to the report, and provide its comments in relation to the review. The committee confirms its wishes to receive further updates as the review progresses, informally via briefing notes until any future recommendation involving any potential change to how services are configured when the committee's formal role in the statutory consultation process would apply.
That's seconded, members. Is that agreed? Agreed. And before you go, I just want to say thank you again, Ed, because we won't see you. And Kate, you thought we forgot about you as well, because we know you're retiring at the end of September. And I wanted to say, I know you've had some difficult times with us, you can say me, us here as well, but you've always done amazingly well. You've always battled for the service and for trying to get equality for all of our residents. We do know that. Obviously, sometimes when we aim our questions at you, we're aiming at the whole system, not just yourself. But we wish you all the very best for the future. And it's going to be a very new team here at the next. I'm sure I'd love to see your briefing notes to them about coming to Hask and Medway. Maybe don't show me them briefing notes, but thank you so much, both of you, for your time and safe journey tonight. Thank you. Thank you, Kate. Thank you. Item 11, please. We've got, no, I'm going forward. Item 9, KMMH, please. We're getting there. Welcome, Sheila. Oh, nameplate. Oh, yeah. Because we know Sheila, see. Welcome, Sheila and Julie. Just to please take the papers as read. I know you've been waiting really patiently in the audience, so thank you so much for that. But if you wanted to just give a brief, any highlights you wanted to just brief the committee on, that'd be great. But welcome tonight and welcome, Julie.
Yeah, thank you. So as you say, I'll take the papers read. I'm just going to do some highlights first, and then I will pass to Julie because she's got a few things she'd like to say as well. So just to go from the kind of start really, and I've said this to the committee before, so you all know we've had a number of external reviews that I've kind of commissioned into the organisation. We've had the CQC findings too. We've accepted all of them, as you know, because we've talked about it previously. But I do want to say that I do understand that has impacted in terms of people's kind of confidence and their perception of us as an organisation. What we wanted to kind of talk through tonight, and I know you've had the paper before, is to show some of the progress that we're making. So our big focus has been around our quality improvement plan. You've heard us talking about that. It's been in the organisation for a year now, but we've made over 194 improvements already in terms of the actions. We've got more that we need to do as well. And Julie, as our chief nurse, has been overseeing that, and we'll talk a little bit more about that. All of our safety warning notices that CQC put in place have now been lifted too as well, which is good news. I just wanted to touch on the recent publication of the National Oversight Framework. No doubt, and we did write to all stakeholders at the time as well, was to let people know that we had moved from segmentation 1 to 3. What I will say is it's things that we've talked about before as a committee, and some of these things are annual surveys that are done. So the movement this time was around the patient survey and the experience, which is an annual survey. So we know that's based on kind of historic, and we've got measures in place now to have kind of more real-time feedback from patients as well. So I just wanted to kind of set that out and say we know there are areas that we need to improve, and that's part of kind of the quality improvement plan we have in place. We've also just launched our new 5-year strategy, which we did in June in the organisation. We've done that a lot with feedback and stakeholders' engagement in terms of where we're going as an organisation. What I would say is the patient focus is already in there, as you would expect it to be. Likewise is the staff experience as well, and that's two of our big kind of themes that we are completely focused on as an organisation. So as I said, the quality improvement plan has been our absolute priority and focus over the last year. It does bring all aspects of the quality improvement that we're doing in the organisation together into one place, so we can give that assurance to us as execs around the work that's been undertaken, but also to our trust board. So it does cover, and the paper says this, around safety, around access, around the environments and the experience that our patients and staff have, but also around kind of leadership, culture and governance. And I just want to stress, which I talked to you about when I was here before, we have a big governance improvement plan in place as well, which we will be taking a substantial update to our board in September. So I just wanted to say we know there are still areas that we need to improve. What I would say is we've seen some real improvement in our access times to our services over the last year. In particular, we've talked before around where we are with dementia, but also in our mental health together teams and our crisis response rates as well. So that feedback, you know, we've been taking we've been making sure that we use that to improve our services kind of going forward. So we have done a big piece of work in Medway in terms of our mental health together team, and we've been trialling a pilot there in terms of how we feel we could improve services further from the feedback that we've had. I'm really pleased to say that pilot has gone really, really well, and we will in the next month or so be rolling that out county-wide. So that's a really good place to be in as an organisation, but also to assure, our patients from the feedback they've given us on staff, we've listened and we are taking that forward. The one final thing I was going to say before I hand over to Julie is I have obviously said before, we recognise there will be scrutiny. We're open to that as well. We're also open to people coming in to kind of hear about what we're doing. So I just open that up to you all again. If you want to come and hear more about our quality improvement plan, then feel free, because we said exactly the same to NHS England last week at our oversight meeting as well. It's just really important that people hear from us firsthand what we're doing.
Just to touch on that, Sheila, I know we're going to be communicating, and I'm going to catch up with you soon. There is something definitely we are going to organise as a HASC about coming to see you and coming actually to site rather than just around the table, because I think there's something much more beneficial in that rather than just seeing. We're happy to see you here, but it's better to come, and maybe Adrian would make sure he's Kate's day off if he knew we were coming. But Julie, over to you briefly.
Hi, good evening. And as Sheila said, you'd be welcome. I'm sure Adrian would love to be there. So no, you'd be very welcome. But as Sheila said, the quality improvement plan is a real driver for us at the moment. When I say it's different to a tick box and checkbox exercise, we're not saying that lightly. The amount of work that has gone into this, and I say that knowing that I can sit here and talk to you about it, and actually what you want to know is how is it being delivered and how is it being embedded. So what we've historically done, and what you'll find in several organisations I've certainly been in previously, is you'll have an area that you're a bit worried about, you put in a checklist and an improvement plan, you tick it off and you go, great, we've covered those areas. And then actually, a little way later down the line, we find that we've kind of gone back round in a circle again. And we know that's happened in our organisation. We know that that was one of the warning notices that we encountered, was exactly that. So the quality improvement plan is a very different vehicle about how to drive that quality improvement. So things actually don't come off the plan particularly easily. They have to be really embedded. We have to see the evidence and the metrics behind it. So as Sheila said, we've got the 4 themes, and that's not just come from the CQC work, that's come from our patient safety incidents, that's come from our wider external reviews, and it's come from staff when they have said, actually, we can recognise that we're a bit worried about something. So we've got the safety and risk, access and waiting times, environment, experience and equity, and leadership, culture and governance. And for each of those 4 areas, we've got a designated SRO who is at deputy exec level. They're driving that. We've got somebody that's pulling the data from our business intelligence team. We've got somebody from our patient experience side that's bringing in the patient experience. We've actually just I've restructured slightly part of my portfolio, and actually our director of AHP has now taken on patient experience. So we've moved some of our powers and complaints into a different area deliberately to give that more focus, and that's all included in our quality improvement plan. I think, as Sheila alluded to, I've lost the number now. You've said 194 actions of what's been delivered. I'm not going to lie, there's a lot more actions on there, and we're adding to it. Every week we have our learning review group, and we're adding actions to it. The message that I'm really clear within the organisation is this isn't about how do we get the actions down, it's about how are we delivering the highest quality care and driving that through. That's been a real change for us. And Adrian and his team have been instrumental in that. So Adrian and I are working really closely, so we've got the improvement team alongside us. A couple of bits I think we have really seen that's been driven by the quality improvement plan. Physical health monitoring for people with a serious mental illness. Our target on that is 85%. You would argue it could be higher. We were at 65%, we're now at 78%. we will hit that 85 and we will go to the next stretch after that. We've brought in, as Sheila was saying, around the patient experience and how that's affected our segmentation. Not only have we got more of a focus on patient experience, but we've launched something called Your Experience Matters. So rather than waiting for the CQC community survey, which is only once a year, we've now got our own survey which incorporates the friends and family, it incorporates wider. We're linking it with our Dialogue Plus assessments as well, and how we're bringing that together. And we're just about to launch a business intelligence dashboard. So everybody, all of our staff will be able to say, where's my team at, where's my service at? And I think that's the other key point with this quality improvement plan. It gives us a trust-wide picture, we can see that, but it lets us drill down. So at any point, we can go into it and I can go, well, actually, what about that Medway team there? One of the areas we know we've got a lot of work to do on, it's not where we want it to be, is around our risk assessments. And I don't say that around the compliance, because the compliance is going up, right? That's kind of easy. We get the compliance up. What we're focusing on is the quality. Because if we get the quality right and we get the assessment of the risk right, the compliance comes second. That just comes as a byproduct of it. So what we've actually done, because it's not where we want it to do, the heads of nursing and quality are now reporting in every 2 weeks. Here's every single service. Here's how our compliance is. Here's how we're linking in with that service and doing that service specific work. So we've stopped looking at almost, here's our overall, great, it's going up. It's really being able to get into a few more specific areas. I think with our community teams, what's happened in Medway with that approach at the front door, with having our partners alongside us, that we've seen that that's been much more successful. So being able to think about how we roll that out wider in the organisation is a step that we're taking at the moment. The reducing waits over 38 weeks, so Medway is on track to be in that position before the target, which is the end of October this year. All of that's being driven through from the quality improvement plan, so it's bringing it all together in one place. We've also got about patient flow in there as well, so we've been working closely with all of our acute partners around corridor care and how we're ensuring mental health patients that are in A&E departments and sometimes on the wards, depending on which hospital, how we're really making sure they've got the support they need and how we actually make sure they're not sitting in A&E. We know that's not a suitable environment, and how we work that forward. So we've had a lot of work internally around our flow. What can we do a bit differently about supporting people so that we're not having delayed discharges, whilst working really closely with social care partners about our clinically ready for discharge, because that's been quite an issue for us.
Is there any extra highlights? Sorry, Julia, it's just that time. I've got to be a bit careful with time. Is there anything else you wanted to? I mean, it's a really good document. You should send that to us, really. Is there anything?
I could talk all night about the quality.
I know you could,
plan.
and it's so good. But is there anything? Is there anything else on you wanted to just quickly highlight, or members are going to ask you questions anyway? So
I know someone mentioned earlier about the use of data. I would just say I think we're heading in the right direction with our data. We've got, I think it was last week or the week before, we've had a business intelligence dashboard now that we can all view that actually has all our patient flow on. So it was just bringing in that, I can't remember who said it, bringing in that point.
Thank you, Julie. Thank you very much. Members. Councillor Wiley.
Good evening. You did mention that you're putting in work so things don't slip back, because, as you said, it's been a circle that's this committee has seen over and over again. It's like slippage. And on page 207 at 3.24, just your waiting lists are still quite long. Is that one of your major concerns? And my third and final point is I've only seen dementia mentioned twice in these papers. Can you tell me the work you're doing with dementia patients, please? Thank you.
Just to be clear, they're really good questions. If it's a big one on your dementia, Sheila and Julie, then we can ask for a briefing paper. I don't want to open up the whole topic. Councillor Wiley knows what I'm saying because we've got so much on. But if there is, I know dementia has been a real concern of members, and I think it's something that we may need a proper update on, or maybe a briefing paper.
In some ways, I would prefer a briefing paper because that can contain more details. But if you could cover it briefly, please.
Yes, we can. Yeah, we'll come back. We'll certainly come back with around the dementia paper. The point you made around embedding the learning, making sure we're not going back round. So, for example, with physical health, we've put in some, as you do, we've put in some audits, we've put in some checks. Actually, what we're not doing is just relying on that. So we've got matrons that are within all the teams that are overseeing some of that. We've also got our corporate physical health team. But what we're bringing in is, where does the oversight for some of that physical health data sit? So we've got our performance and quality review, our performance reviews that happen every month within the teams. Previously, that hasn't been featured in there, so that's now embedded in that. So it's making sure that we're using the governance structures we've already got to bring things in so that we've got that oversight on a longer basis rather than just a shorter term piece of work.
Sheila?
Yeah, thank you. So as Julie's just said, in terms of kind of the embedding, and Julie talked a lot when she was just giving our update in terms of us making sure we've got live dashboards we could be using for us being able to check, you know, the quality metrics that we're looking at in terms of the quality improvement plan, but also where we are from a performance perspective. It's about having that kind of live data. So that's very new, and that's something we've been building alongside the quality improvement plan in the last year. And that's our way of really being able to think. And as Julie's talked about audits as well, we learned our lesson around one of the warning notices in terms of what we did. We rolled something out, assumed it was embedded, and it wasn't. So the audit bits are really important for us in terms of follow-up. Just to pick up on weights and where we are, and we can provide more around dementia, that's not a problem at all. But so we have gone from a kind of a trust-wide position in terms of our waiting times in terms of 18 weeks, from 65.9% in February to 77% in June. So it's moving completely in the right direction. And our waiting times for mental health together and how long, we reduced them by about 10% in the last year. So that's working with partners, which is why we're confident the pilot we've just done in Medway will enable us to be able to reduce them further. So again, for Medway, in a good position at 75.4% in terms of 18 weeks. Around dementia, we can do a briefing paper. We have done a lot, and it was a big part of our last kind of strategy. I'm confident to say that our weights were up at 26 weeks when we kind of originally started. We're now at like 13 weeks for people waiting for a dementia kind of diagnosis. What I would say is, though, we've moved from all the work we've done in the last year from being one of the worst performing in the country to almost being one of the best performing in the country. So that's why I'm really confident around kind of our strategy and our doing well together improvement approach, which Adrian runs for us, which is around our continuous improvement. We've driven that approach through the dementia work we've done and seen significant improvements and been able to sustain that. So we're taking the same approach as well to all of our other waiting times, especially around mental health together, which is why I'm confident we'll be able to kind of sustain that going forward as well.
Thank you very much.
If I can just say, and I'm sure our group and the committee would welcome a visit to see, yes, cheers, thank you.
Councillor Jackson?
Mine is really quick, and it's not really a question. It's just to say, in all fair, when we scrutinise you, also my daughter uses your service, and I want to say publicly it has changed out of sight since March to July, to the point where things that were worrying me, she is suicidal, she didn't make one of her appointments, she was contacted, she didn't answer, they then phoned me and sat on the phone for me for an hour talking. So thank you. It's completely a different service that we're receiving now, so thank you.
That's great to hear. Thank you, Councillor Jackson. That's really good, because it was a concern before, wasn't it? Two really quick ones from me. They're never that quick, but we talk about the 194 improvement actions, but you did say, you've already said, Sheila, you've gone from segment 1 to segment 3. Is there a risk maybe that, or a danger that you're measuring activity, more rather than actual improvement? I know you are improving, but it's that measuring, it's that weird measuring, isn't it? How you're doing so well, but you've gone, sorry members, just to remind you that you've gone from 1 to 3, but the improvements are very visible. And I will say that from a HASC, they're very visible. So are you worried that there is a danger you are measuring activity too much more than improvement, or are you doing both the same?
I would say we're absolutely doing both, and that's been our big learning in the kind of last year. The NOF is as Julie said, is the annual patient survey, which is why we brought in the Your Experience Matters in April, so we can be monitoring that more routinely on a monthly basis, because an annual basis means actually we're now in the position that we're going to be sat here talking to you about the NOF, and when it's published again, that it's an annual thing. There's nothing we can do about that. Likewise for the patient experience, for the staff survey as well, because they're both annual scores. What we are doing as a team is looking at the National Oversight Framework, because regardless of what people might have an opinion of it, it's here to stay. So we are looking at the things which has got access in it, it's got the experience from staff, it's got the experience from patient, and other things that we need to be making sure we're monitoring and really thinking about where's the areas we can improve, because we don't want to stay in segment 3. We want to get back to segment 2 at least. So we're looking at what we can do differently that will, take us to segment 2.
Is there anything worrying you, Julie or Sheila, in Medway? Any of your services worrying you in Medway at all? They're worrying you might find unacceptable at the moment, or they're a bit of a concern? Any services in Medway?
It's really good to hear that things are improving and that's being seen. And I 100% agree with that. I can look back to where we were saying it the other day, a year ago, and to where we are now. Are we where we would like us to be? No. So I think, I think we've still got a lot of work to do around the risk assessments. I think we've got work to do around involving families and carers more than where we have. So that would go for all of the teams.
So nothing of major concern. Sheila, you've got something of major?
No. So I just wanted to say thank you for the feedback.
Yeah,
We appreciate
no,
it.
it's really good.
Just to agree with what Julie said, there isn't anything of major concern in Medway, and actually what Julie and I were reflecting on when we were coming here this evening is when we look across the whole board of the organisation, and we look, as you know, we're structured in kind of directorates in the organisation, and Medway is part of our North. Our North Directorate is doing the best probably across most of our performance from a waiting time perspective, from a quality perspective, from a staff feedback perspective as well. So there isn't anything specifically at this moment in time.
Just a final one, and I will give the last word to Councillor Perfect. I think it's like seamless. You haven't seen my questions, so I want to make, but I was going to now talk about staff engagement. And staff survey is something we always ask Adrian all the time, because you measure, don't you, your improvement in your organisation by your staff and how they're seeing the improvements. And you don't have to give us it now, but you will. I know you'll be doing, or whether you've done it already, but it will be good at some point when you're back, because I know you come back quite often. It'd be good to see that staff survey or that staff engagement, just to make sure, your staff can genuinely, some may always say there's something more you could do, but your staff are the heroes, aren't they, of the organisation? I've said that to you time and time again. They're the front line, and they are the ones that would genuinely see change and be able to feel the change. I can sense there is change. That'd be good maybe in time to see your staff. I'm just quickly, Sheila, from you, is there a feeling from your staff that there is change?
So I would say, so just to go back to what you said as well, which is, our people, we're incredibly proud of them. They work hard every single day. We know they do, and they want to do the right thing for the patient, which, always inspires kind of Julie and I on any of the visits that we're doing to services. The bit that I would say around staff is we know that we've got really pockets of staff that are really happy, love working in the organisation, and we know we've got some variation where people are less happy. As I said, in this part of the patch, so up in the north, so which includes Medway, I would say our staff survey results are better. I'm happy to bring something back here. And what I was just going to add, so in our public board in September, we're going to be doing a bit of a deep dive. So it will be in the public papers for people to see, looking at kind of our culture in the organisation, looking at what feedback we're getting from staff, looking at teams in particular, but laying across that where kind of from a quality lens, from a performance lens, so we get a bit of a rounded view around what's happening in the organisation. So if staff are unhappy, is that impacting kind of the performance, what's happening with quality? So that's coming to our September board. So I'm happy for us to bring something back because that will be in public as well.
And like, you know, like any organisation, you have to improve, and that improvement journey is there. And if people don't want to improve with you, then they have alternatives, don't they? Councillor Perfect, just briefly, please. I didn't see your hand before, so just briefly.
It's okay, thank you, Chair. No, I just wanted to say, I was going to make the point that you were making about staff in engagement, so great minds. The other point I just wanted to make, because I know last time, Sheila, we had this discussion just about the both leadership culture and governance, and also the board. I was pleased to see that obviously your board arrangements now seem to be a little bit more stable in terms of the new chair in Colin Lynch that's joined the organisation. So very pleased to see that. And also very pleased to see the addition of a couple of other non-executives as well, which seem to be hopefully assisting with that flow in terms of the sort of oversight of the organisation. So I just wanted to, because I know I was quite critical previously about some of the changes that have been happening. I'm pleased to see that they've now been remedied. So thank you, Chair.
Thank you, Councillor Perfect. And you know, it would be good at some point, not now, I don't want you going back to the load and Terry be saying to me, well, I'm filling up our agenda. But it is nice to, you know, please make sure your chair does show themselves at some point. We will call you in the chair. As you know, Sheila, we do. It'd be good just to get the reassurance, not only from you guys, which are the main ones, but also the board as well. It'd be just there. And before I go to the vice chair, can I just say it just proves tonight, and I want members to know, it just proves that transparency where we started, as you remember I said about poor Adrian when he first came here, the transparency and openness and bringing us on the journey helps. It isn't, you know, we will still question, we will still scrutinise, but I've noticed you do keep me informed, you do keep us informed. There is a good link with Terry, isn't there, Terry, in that, and it just helps the process. It helps us understand what an organisation is going through and the improvement journey. And the more, whatever you want to tell us, Sheila, I know, but it's the more you tell us, the more we understand if there's an issue, or if making sure you tell us if there's an issue or something major happening. The quicker we know, the better journey it is for all of us here. Vice Chair.
So the committee requests a briefing on dementia services and results of staff engagement. And I move that the committee notes the update from KMMH and the ICB as set out at Appendix 1 to the report.
Thank you very much. That seconded? And agreed, members? Agreed. Thank you so much for your time. Thank you, Julian. Thank you, Sheila. You might want to send that little pack to Terry, that little update you gave us there. It was quite interesting. Thank you. I am gonna do, if I can ask MFT members to come up, there is gonna be just a very quick 5-minute, and I've been signalled by some members, just a 5-minute break, but back straight, and I'm gonna call you back in literally less than 5 minutes, if that's okay. Sorry, guys, you can come up and sit up. Can I just thank, I've got to thank Siobhan and Jeremy for waiting. Thank you. You've been waiting so patiently. And Siobhan, just as you know, it wasn't just under 12 hours ago, I was seeing you as well. So you've had a long day, same as we have. So again, please take the papers read. But if we go about patient safety in ENT, do you want to, I don't know if there's a highlight you want to do at the very beginning. And it'd be really good, Jeremy, if you want to introduce yourself to the members.
Yes, certainly. So I'm Jeremy Davis. I'm the Acting Chief Medical Officer at Medway. And we'll just take this not quite in the order of papers, if that's okay, Chair, because you wanted the ENT stuff first and then...
patient safety and ENT
patient
on this
safety.
item.
So Siobhan's going to speak to patient safety and I'll speak to ENT.
Yeah, good evening, everybody. I'm Siobhan Cannon. I'm the interim chief exec at MFT. And I just wanted to talk to you about our patient safety incident backlog that we identified. So you'll have read the paper, and it's really important. I just want to say, first of all, this is part of our transparency. This is part of us identifying a problem within the organisation and being really clear this is unacceptable, and being clear with not just our staff, but with the public about what we had found, to redress the backlog, to give it really due diligence, how we were investigating that, to make sure that our systems and processes were in place so this doesn't happen again, and how do we deal with the backlog. I'm pleased to say we've made really good progress with that, and we envisage that we will have closed all of those investigations by the end of October. We've also been really clear with other interested parties who've been involved in that, such as the families, because you'll see some of the duty of candours hadn't been adhered to. Some of them we couldn't evidence that it happened because they were in the notes, but we were really clear we wanted to be thorough and revisit all of that. So we have changed the structure within the team. We've changed reporting arrangements. We've re-looked at our governance structure. We had some external scrutiny and support with that. And we continue to invite scrutiny to those committees, the assurance committees as well. So we have CQC representative on that to make sure that they are satisfied with what they're hearing. We're really very clear with our staff around declaring incidents. Don't stop declaring. We'd rather have a higher reporting of incidents and look for a reduction in the harm that is caused by those incidents, which would evidence our learning. So what's really important about the backlog is not just the clearing of the numbers, but it's actually what learning have we got from those incidents, and what have we put in place, and then how we're monitoring that. So I'm happy to take any questions.
Thank you, Siobhan. Jeremy, do you want to add on about the ENT? We're taking it as double.
Yeah, so the ENT side of things is about our service at Darrant Valley Hospital. So the Medway ENT service provides services at Medway, the local population here, and at Darrant Valley. And this only affected patients who were being seen at Darrant Valley. During COVID, ENT nationally and locally was hit quite hard in terms of being able to deal with routine patients. We managed to continue with cancer. ENT is a specialty that was very much involved in the COVID pandemic, a lot of tracheostomies, a lot of acute care during that time. And so backlogs did build up during COVID, and that's been a national problem for ENT. The issue was that at the Darrant Valley end of our service, due to the way the two trusts' information technology came together, there was an unknown backlog at Darrant Valley that hadn't been recognised. So 2025, that became clear, and once it was validated, there were just under 9,000 patients, about half of them new patients who should have been seen, and about half of them follow-up patients who needed seeing. Now, once that became clear, very swift action was taken, and to the extent that by March of this year, so slightly less than a year later, the ENT waiting times had got to be some of the best in the country. So the actions were taken swiftly to address this. There's been an external NHS England report which has raised a number of reasons and concerns why this happened, and we absolutely apologise for that to the patients concerned. It also made around 14 recommendations. 10 of those, to my mind, the most important ones, have now been completed, so that we're assured that we now have full oversight of our patients. We're using the Medway systems to track all our patients, including those patients being seen at Darrant Valley. And the final elements of that NHS.
We had the ENT here as reported. So that the questions and the stats around that, obviously we did, and thank you, Jeremy, for reminding us. There was intense scrutiny at that meeting, I do remember. So just if there's any questions on the relevant stuff now in the report that's in today, and also on patient safety ONT, please answer. And can we keep the questions very tight, please, members? Who would like to go first? Councillor Waddy.
Where we were was totally unacceptable, as I think everybody agrees. And it is more of a comment. The way you've dealt with the crisis is as good as it could have been. The waiting list for some people is still not as they would like. It is very easy to criticise, and it's deserved criticism for the past, and it's unlike me to almost congratulate you on the way that you've dealt with it, which isn't a question in any sense at all, but yes, for once, well done, but there's still more to do.
Thank you for that. And we need to continue to improve those RTT times in ENT. So although we may be at the better end of the country now, that doesn't mean we can't do better. And we're continuing to learn. We've got a really good team working who are determined to bring it down further. Thank you.
Councillor Brown. Jeremy, is your mic on or is it off? Is it off?
I think it's off. Firstly, thank you both for your reports and your candour. I just wanted to ask Siobhan about the what's your feeling around the sort of prioritisation of the reporting and the risk level? Do you feel that people are confident enough to report like all the high risk stuff first?
Thank you. Yeah, it's a really good question. So what we've implemented, we had before, but it didn't have the scrutiny or the openness it has now. So we have a weekly incident review meeting where anyone with any incident at any level can bring to that group and say, I've got this concern. If they've maybe filled out a DATEX, that's our usual incident reporting mechanism within the organisation, and they bring it and they say, it might be a very obvious patient injury or incident, or it might not be. It might be we've missed something. And they're encouraged to bring that. So we have an open discussion. And then the debate within the room, it's multidisciplinary, is what level of investigation does that need? Is that about local learning? Is that we think this has got wider learning for the organisation or indeed for the NHS? And that would be a PSERF investigation, so patient safety incident. And then there's different levels within that you can use as well. And what's really important is that we include the families and the patient in that. So for patients being harmed and the family want to be included and they've got questions, it's really important. And recent experience from myself and with patients is that we get better outcomes and embed learning better when we include our patients and families in that.
Thank you very much for that. I'm glad you're building confidence in people to do the reporting, because it is part of what will make it successful for everybody.
Yeah, and I think that's part of our culture work as well, is to make sure that our staff voices are heard. It's really important that if they feel a wrong has been done or something's been missed, that they have the courage to say that. Now, they can do it formally through our DATEX, and we would encourage people to do that. And you can even DATEX anonymously, if anyone is worried. But we also have our Freedom Speak Up Guardian. We have our listening advocates as well. But what I have seen in that meeting, because it takes place in our open plan office, is I can hear the staff bringing concerns and really good discussions around no one's told, put that away, we don't want to talk about that one, or, oh, well, that would have happened anyway. Nothing to see here. What we're hearing are really good discussions and also really good support and challenge from our CMO and our CNO around, is this right? Should we have an external review on this? This related to an incident we heard 2 weeks ago. Should we do, a thematic review around that? So we're starting to get that language of openness, no blame, because as an organisation, we should have the system and processes in place to enable our staff to deliver safe care.
Thank you, Councillor Brown. I think, Siobhan, and for you, Jeremy, I just want to reiterate again, when you did come last time, you know, that candour and transparency is really important. We were made aware of the incident, the long waiting list, etc. Obviously, it's unacceptable. Thankfully, you've got everyone, you got everyone and you made sure everyone was looked at, which especially the priority ones. That was the biggest worry, wasn't it? But these things do happen at times. But it was because of the transparency and the candour and being upfront. Why I think it's an easy one for us tonight to thank you for doing well on that and for getting us a good result. Councillor Garvin, you got a quick question? Because I didn't see it before it come to me.
I've got an example, one terribly bad and one absolutely brilliant from the same hospital in Medway. I actually had some ENT work done last year, and it was absolutely brilliant. The problem I was dealt with quickly, within a week or two of the problem being flagged up. Apart from having an I couldn't fault the treatment. But on the other hand, after my prostate cancer, I had no follow-up. Immediately after the operation I did. And it was nearly a year later, I suddenly realised I hadn't had a PSA test done. So I went to the hospital myself, to urology, got the form, and went off and got the blood test. When the results came back, the prostate cancer had come back. And, I feel that should have been... So, I just don't know how you can manage, in some respects, to be so very good, and then with the same pay, different departments, I must admit. But, it's almost unforgivable what happened over the prostate cancer business, because I've now found it's absolutely incurable. And I'm no longer under Medway, I'm under the Royal Marsden. But, sometimes you can do absolutely brilliantly, and other times you just foul up totally. So there's something culturally wrong there in some bits, because there's some brilliant service there, which, as I said, with the ENT part, I couldn't praise the treatment I had highly enough, but the cancer treatment was...
Just as we've heard from other colleagues speaking earlier today, nobody's ever going to be able to guarantee that everybody will get absolutely 100% safe treatment. What I'd like to ask is, at the end, afterwards, if we could just take your details, which I will go and make sure that we've examined so that we can learn from your experience. I'm really sorry about that.
What I do is I can... Terry, Councillor Garvin, Terry can put you guys in touch and do it that way. It'd be easier. We make sure that happens, because it's, again, I know that's something you want Siobhan as well. It's about that learning, and everything is a new learning, isn't it? I think we can't miss that. It's a really important point you make, Adrian, and I think we should always make sure that's not missed in the process. Did you want to say something, Siobhan? Are you okay? You're okay. Okay, fine. Thank you. Okay, Vice Chair.
I move that the committee notes the update reports from MFT as set out at Appendix 1 and 2 to the report.
Seconded, members? Agreed? Agreed. Thank you very much. I was going to say you can't go away, because we move on to the next one now for you. So we've got item 11, urgent and emergency care. Can I just say, Siobhan, just a quick highlight at the beginning, because take the papers as read, please.
Okay, thank you. Thank you, Dan. So I've been in this chair before talking about corridor care. Since then, the Central NHS have given directions around corridor care and about eliminating corridor care. And I suppose the first thing I want to say is it's not just about corridor care. It's about care being delivered that is not a designated patient space. So if it doesn't have oxygen and suction and curtains around it and is a safe place to be treating patients, then we shouldn't be treating them there. Unfortunately, at Medway, we have corridor care. So we have a programme that we've joined with as part of the system. So it's been led by our system transformation lead. And we're working really closely with mental health colleagues, local authority colleagues, community, to tackle what are the drivers for corridor care? So some of those drivers will be internal working within the organisation. Are we efficient at discharging our patients, at getting them out, getting them back to their best bed, wherever that bed might be? Or do we have inappropriate admissions coming into the hospital as well, or just even presenting? So it's a multifactorial issue which we're looking to address. We're quite excited because we've got various areas within the hospital, I won't go into it geographically, around ED, and we have closed the external corridor. We don't use that anymore. It has to be escalated to an exec to get there, and generally they go down to the department and go, no, you're not. We need to be moving these patients, we need to be doing this. So very proactive, and Jeremy could probably give you some examples of that, which is really good. I think one of the first things that we decided as an organisation when we were tackling this was we have to say it's zero tolerance. If we wouldn't accept it for one of our own, why would we accept it for our patients? And to be fair to our staff, they do not want to look after patients in a corridor. Nobody does. We are committed to maintaining our ambulance transfers and handovers. They're really good because it's really important we keep the ambulances out on the road, but equally it's important that we manage the patients that are in our care safely and timely, and then right through the hospital, through the other end of the hospital, which is around discharge and getting them to that best bed, wherever that bed might be. So I'll leave it there.
Members. Councillor Perfect. Okay, I've got a few. Keep into questions, please. Just type questions.
Yeah, thank you, and thank you, Siobhan. Yeah, I mean, I think I agree with you. I mean, I think, you know, with the 5th largest economy in the world, we shouldn't be caring for anybody in a corridor. I mean, the fact that we've even as a country let ourselves get into that state is a pretty, pretty poor. I'm just interested particularly in the virtual hospital and virtual ward arrangements. I was talking to a resident recently who got in touch with me who their daughter had been quite ill and had been recovering from a long-term emergency condition that led to sepsis, and had actually found this particularly positive actually in terms of their daughter was able to go back home. She was away from the hospital, but also they felt like there was a real connection back to the hospital. So I think, you know, certainly the points that you're making from sort of 6 to, well, the whole of point 6 really, I think broadly, certainly from the experience that I've had from that particular resident was pretty strong. I'm just interested in terms of how we're embedding that more broadly. I mean, you're talking in 6.5 about ongoing discussions with the council about the interaction between hospital at home and social care. I'm just wondering if there was anything specifically that you're, Leanne, feel free to comment, just specifically that you're looking for from adult social care and how you're finding those conversations in terms of that, and what sort of the sort of, I guess, the potential is with this longer term once it's fully embedded, in terms of how that you would see that linking in with your own capacity and how that might alleviate some of the challenges coming back to the corridor care point sort of more broadly, because noting at the moment obviously that whilst it's growing, it's still sort of in its early infant stages nationally. Thank you, Chair.
Yes, so we're working really closely with local authority colleagues. It's been fantastic. And so we have visibility in the building every day. We have a daily drumbeat. We have 2 meetings, one in the morning and one in the afternoon, very specifically around some of our long-term patients as well. But we're also looking at our front door and how we can turn them around at the front door. So really important working with the community colleagues and MCH as well. So we're seeing that quite energising, not just for patients in virtual ward, but to actually get patients back to their, as I keep calling it, their best bed, because it might not, you know, it could be a nursing home bed or a care home or whatever. So the relations are really good. So I think traditionally at Medway we would have sat in the building and gone, it's everybody else's fault, it's not ours. And I think what this project has taught us is we've got a lot of stuff we need to get right internally in the hospital. You know, I point you to our clinical operational standards, so our response times to A&E, ED. So, you know, if a doctor in ED said, well, I think this patient needs to be seen by surgery, how soon do our surgeons come down to see that patient? How soon do we do a blood test? How soon? So we're measuring all of those touch points, so we can talk to our clinicians and say, you know, this is what we're seeing, this is the evidence of it, engaging with the speciality teams, and going into real detail, like, you know, if they're expected to respond to A&E really promptly, have we job planned them to do that? Or have we given them a clinic that they can't get out of until 5 o'clock and you've called them at 1 to be down in ED? So there's a lot of kind of common sense housekeeping that we need to get. But in terms of local authority, I think we're working really well. And I think we're seeing the evidence of that with reducing corridor care, but also reducing length of stay. So even for our no criteria to reside patients, we've seen a reduction in length of stay. We've seen a reduction in length of stay in our virtual hospital as well. So we're starting to see an impact, but clearly because it's so entrenched, we need that further push, and that would more than likely be around our frailty model, I would say, with where we would concentrate.
Thank you very much. I've got Councillor Campbell and Councillor Cook, and then I think we move on from that close. Just you two left.
Thank you, Chair. One of the themes we have consistently touched upon in this committee has been patients who are ready for discharge, but there's no place for them to go to safely. So they kind of take up beds which could be released. So it's really heartening to see in this report that you've made some significant progress with that. And there's a real drop in the number of days. 13 days. I mean, that's huge to reduce up to 13 days for somebody who's in the hospital. However, what is the longest stay? Like how are you averaging at the moment in terms of how long people are still at hospital without being able to be discharged safely? I'm just asking you to describe the worst case scenario, basically.
We do have patients who are there for months.
You can come back on that, can you? We'll be able to give that detail?
Yeah,
Come back
certainly.
on that detail?
Yeah, certainly. Because we put our patients into, sorry, but we categorize, P1, P2. So pathway 1, pathway 2, pathway 3, pathway 4. And some of them will have very complex needs. So might need neuro rehab, neuro rehabilitation, or might be multifaceted. So might have a dementia with other comorbidities as well, which makes them quite complex to be able to place safely. And then others will be around the fabric of their home or their environment and things like that. So most certainly we can send that level of detail to the committee. Happy to do that.
Thank you very much. Thank you, Councillor Campbell. Councillor Cook, finally, please.
Yeah, thank you. Just kind of briefly thinking about some of the wider themes we've been speaking about throughout the meeting. Obviously, really important that nobody experiences corridor care, and I really appreciate that, but particularly for those with wider vulnerabilities. So, autistic family members who are really, really upset by seeing the pain of others. What is the hospital doing to make sure that those with those particular vulnerabilities, of which, a neurodifference might be one, but there'll be many others, are given even more support in never having to experience corridor care? Thank you.
Yeah, again, I think it's a really good challenge for us as an organisation to identify quiet and calmer areas for those individuals who find ED kind of hypersensitive and really triggers for them as well. And we've picked this up through some of our incidents, but also through some of our complaints and feedback from our families. So we're working very closely with our safeguarding and our LD team to kind of identify where those areas are and try and prioritise and pull those patients out of ED, or if not, find a quieter area for them. We are working really closely with our mental health colleagues. I don't know if you've heard, but we secured bid for to have our mental health hub at Medway. So that would be really good for that cohort of patients. But appreciate lots of patients will have issues, but I think we do need to focus on those who are very vulnerable and find that a really traumatic environment to be in.
Okay, Siobhan, I could ask a load, but I'm not going to tonight, so don't worry. I just want to say corridor care has to stop. I mean, it has to, and I know that's what you believe as well. I spent 38 hours in a corridor at MFT on a bed, and it isn't good. And actually, what was more insightful was I was helping a lot of the other patients, the elderly ones that were around me. Even going to toilet, even going everything else. I think, we all know, it's no good us going on about tonight, we all know that corridor care has to stop. I know it's difficult at the moment, but really it isn't acceptable for anyone, is it? It just isn't. But Vice Chair.
So I've got some information to come about patients who are resident when there is no safe discharge route available. And then I move that the committee notes the update reports from MFT as set out at Appendix 1 and 2 to the report.
Is that seconded? And agreed, members? Agreed. Thank you very much. Thank you, Siobhan. Thank you, Jeremy. Thank you for all your time. I'm sitting here talking. Oh, sorry. Moving on to item 12, we've got council plan monitoring.
Thank you, Chair.
Over to you, Leanne, very briefly. Members, just to listen, if we can, please.
Just very quickly, I'll deal with the adult social care. So 4 reds there. 3 of them I'm concerned, but I'm not overly concerned. The percentage that put us into red is anywhere between 2 and 6% lack of meeting targets. So we're there or thereabouts, Chair. What I am concerned about is page 264, OMCP 1.19. I've asked our analysts to look at this because you'll see that we've got 2 quarters that are reading exactly the same, and that is, it could be a coincidence, but I'm always mindful that when something like that happens over 2 quarters, there's something amiss. So I will look at that, Chair, and get back to you and any other questions anybody has.
Much, members. Council plan monitoring. Councillor Wiley.
It's got to be concerning that, you know, there are more red and amber areas month on month. You know, there is a strategy from this administration, and is that being updated, re-looked at, you know, month on month? Are you looking at how to improve the situation strategically instead of just working on the one area at a time? And hopefully the answer is yes, but it has to be asked.
Yes.
Well, yes, can you give us a bit more?
Yeah, that's absolutely true. And in the round, there are some quite good achievements. But some of these are quite delicate, if you like. If one is thrown out, it will be a knock-on effect. So you're absolutely right about our whole system strategic look at this, and we do that. But they're reported to you, as you've rightly highlighted, in a silo effect. So the answer is yes.
Okay, all right, thank you.
Councillor Perfect.
Yeah, I mean, thank you. Thank you, Leanne. I mean, I think the concern, well, I have a number of concerns more broadly about the strategic side of our people's services, which I think, irrespective of, and at the budget I made clear my views, and I've made them very clear in the media in terms of where the council is at. And I'm not going to go into a political sort of tirade here, because I think some of this actually isn't political. Some of this is a more broader problem facing local government, and particularly upper tier authorities. But there is a political element to this, and I have, specifically pertaining to this report, I have a number of concerns about our ability to deliver in the next financial year and for the rest of this financial year some of these things alongside that very delicate financial situation, which is still unresolved as far as I'm concerned at the moment. And I think we can write to the Secretary of State, we can make those positions, but I don't think it'll come to anything, because we've never seen a settlement for an authority, outside of the wider, local government funding settlement that's agreed. So it'll be back through EFS. I guess coming to my question specifically on this report, a number of these outcomes are dependent on us having high quality social care services. I guess my concern is around, because we have the acuteness of the financial situation, is any of that going to impact on any of these outcomes? And for the service more generally in terms of performance, what is the sort of, I guess, the feeling amongst staff in particular around that financial situation, and how that might alter how staff may take decisions, or how they may sort of, feel about their ability to deliver, I guess. Thank you, Chair.
There is no doubt that to deliver high quality services, you have to have a reasonable resource. There is a correlation there. Nevertheless, staff, in terms of their day-to-day work, can be rightly proud of what they do. There is some really good work going on. I won't comment here about the political side of what you've said. I think people can make up their mind about that. There's a national issue. It's well rehearsed in the media currently. Baroness Casey, etc., etc. But there is no doubt that it becomes much harder when you have a lack of resource in some respects, or resource in an area that needs rebasing, for example. So, yeah, thank you.
I think it's a fair point from all, and I think you'd even agree, Councillor Purve. I think we look at years and years and years of underinvestment, not just any single government, but years of not enough into social care and children. It's clear. I think you're right. Vice Chair.
I move that the committee notes the Q1 2026-27 progress of the performance indicators used to monitor progress of the Council's priorities as set out in Appendix 1 to the report, and notes the strategic risk summary as set out in Appendix 2 to the report.
Is that seconded, members? Seconded? Agreed? Agreed. Thank you. I'm moving on to item. Members, are you, like we normally do, are you content that we take in, from Andy, we take in items 13 and 14 together? That's what we do. And Andy, please take the item as read. If there's anything you want to say briefly, but just as read, really is the best.
Yeah, I'm not going to say very much. All the information's in the report, but it's the first round of monitoring. It's been to Cabinet already in early August. Happy to take any questions.
Thank you, Andy. Members?
Again, on the adult social care projected overspend, and I think that, the report says that they may be able to find, £9 million worth of cuts. Are they cuts, and what sort of services will be affected? And that still only gets us down to a still unmanageable overspend.
I'm just going to ask Leanne to comment on that briefly rather than Andy.
I think it would be a mistake to talk about that identified saving as cuts, because some of it will be efficiencies, some of it will be doing things differently. It is a big ask, it is a big number. I acknowledge that. Staff are working to the best of their ability to try and turn that round. And again, sourcing back to what I said under the previous item, this is a national issue, and Medway is not immune to that.
If I can, I do understand the demographics will be a major area. Can I ask, though, on the FIT savings, I think there's been in different budgets for, well, seems like many years, there's going to be savings by FIT, and I think in this report they say they're going to save nearly £6 million. Is that feasible, or is that a budgetary figure that's quite nice to bring forward?
Leanne again. Andy?
I'll go first. That's the target. That's what we're aiming for. And sitting here tonight, I have every faith that we will get there. There's still a number of quarters to go, and we've heard tonight the absolute complexity of a system. But sitting here tonight, all I can say is that is a target. That is what we are driving to.
You content with that?
Andy, want to come in?
No, I'll concur with Leanne. I think all services are working hard on the FIT plan to achieve the targeted savings that are in there. So they're all working hard to reach.
I move that the committee notes the results of the first round of capital budget monitoring for 2026-27, the results of the first round of revenue budget monitoring for 26-27, that Cabinet instructed the corporate management team to implement urgent actions to bring expenditure back within the budget agreed by full council.
That agreed. Remember, seconded. Sorry, agreed. Thank you. Item 15, work programme. Terry.
Thank you, Chair. I've got nothing apart from one little thing to add, is that for October, if members are content, we need to add the annual report of the adult social care complaints and compliments.
I'm sure members can. Councillor Wildy?
Just a quick comment. Today we got the supplementary agenda sent out at 2 o'clock when the meeting was at 6. Now, it was only 3 pages, so that's, manageable, but as looking forward, if it's ever a proper report, that, you know, that simply would not work.
Can I
it's
just, can I just say on that,
yeah.
but Councillor Riley, can I just say, I think that was a really good thing they got them to us, because normally their minutes wouldn't have been, please jump in, then minutes would have been next week, they would have been completed. We wanted them ready, like, they didn't have to do it, the team didn't promise they'd do it, but they done them early for it to give us information, as Councillor Perfect knows, because those of us that are children, who just give you an insight, it wasn't mandatory to give you that. The team wanted to try their best, and they did. I think it was it was. Terry, do you want to just come in?
Yeah, if I could just come in, I completely appreciate that 4 hours notice isn't ideal. Our standard target in the team for publishing minutes is 10 working days. These were done in 5, and they've not been published, they're just draft. The importance of them for you this evening was so that you understood the context. For those of you that weren't there and haven't watched the live stream of the meeting last week, it was so that you understood what those discussions had involved and what had happened, to also avoid any repetition for a long agenda this evening. I felt, and I may have been wrong, it was better to give you 4 hours rather than nothing, but I appreciate that isn't ideal. So I do apologise about that.
Okay, thank you.
Yeah, it definitely wasn't. We do take on what you're saying. Can I just say one thing to members? I think, look, we've been here since 6 o'clock. We've done a lot of agenda items tonight, too many agenda items really, and it is quite pressured. And I'd never want to rush agenda items. I never want to rush each item that we talk to. And if they we had to give that hour and a half, I believe, to that hour and 20 minutes to ADHD, because it was such an important topic, and I believe that we needed to do that. In an ideal world, we should have given everyone, but I think you've all done really well tonight in questioning each of the people that have come here. I just want to pre-warn you, though, is that the way it goes, Terry and I are meeting with Wayne, the way it's looking is that, we may need to add another meeting to the agenda. October's already looking, it could be two meetings instead of one. We are going to try, and I know Leanne will be part of that as well, we're trying to get our statutory partners to be much tighter and to make sure we get items in one instead of separate ones. But, I really want to put on record, I thank everyone, including our subs tonight, thank you all for pushing through. And I'm not going to keep staff here gone 9:30 if I can help it. I'm just not going to do it. It's not fair on officers. It's not fair on us as well, but that's what we do. But it's certainly not fair on officers, and I'm trying never to do that. But just giving you pre-warning that there may be an extra meeting added, just to let you know. Okay, Vice Chair.
I move that we note the report and agree the work programme as set out at Appendix 1 to the report, subject to accepting the proposed changes outlined in italic text on Appendix 1. I also move that we agree that the scrutiny of the supported accommodation strategy be undertaken by the Business Support Overview and Scrutiny Committee, subject to invitations for participation being extended to the representatives from the other committees as set out in Section 6 of the report.
Is that seconded, members? And agreed? Agreed. Thank you, Leanne, and all the officers, and thank you so much, Terry, for your support as usual. Good evening, everyone. Thank you very much.